Does it bugger the whole thing up?
I think you should do it at the beginning.
Well, opinions.
Good morning, all. I call you to attention. Very pleased to see you all this morning. We've already had round one with the extraordinary system board meeting. Please know that went really well. So effectively this is round two. Welcome to our public board meeting. So just so you know, this meeting is being live streamed. So there will be members of the public and colleagues, no doubt, watching our meeting. We're also taking our minutes using artificial intelligence, so you do need to be sure that when you speak into a microphone, because the quality of the minutes we produce are predicted by how well we manage to record the meeting. So speak up and make sure you use a microphone. So there are some particular welcomes this morning. A welcome to Max Jones. Max is with us for a year. He's working as our CDIO, but a lot more besides. So you're very welcome, Max. We're very pleased to have you with us, and we're grateful to the work that you've already done. And the board will have seen the very significant paper that Max has prepared for us later today. We're also welcoming Richard Gladman. Richard is a new non-executive director to the board, joining Mark Chamberlain and Stuart Watson as the non-executive team. We're also welcoming Brent Kilmurray, who's the Chief Executive of TUV, and his Chief Nurse, Beverly Murphy. You're both very welcome here. I'm sorry it's such a long way between us. That it just has to be that way. It's not symbolic. But it's great that you're here. And in fact, just a quick heads up to say, so you can just think about this for 2 minutes. I think why don't we do your piece first? And then you can be in and out pretty. You don't need to sit through the whole our board meeting. So we'll ask you to go first. In terms of apologies, we've got apologies from Charlie Jeffrey, from Councillor Stan Shreve, from Councillor Michael Harrison. Jonathan Owen will be leaving us early and not returning. Michelle will be leaving us and returning. And Simon Morritt has already left, but he'll be returning. I think I'm across that. So there's a little bit of moving parts. And of course, we have apologies from Helen Grimwood as well today. I don't think I've missed anything there. As best I know, nobody's raised any particular declarations of interest. There's nothing anyone wants to raise in respect of any matters of interest in this agenda. Okay, let's move on to the minutes then. So remember, the minutes that we're looking at are the minutes from the last time the board met in public. We have to approve these minutes, so I'm going to ask you first, are there any matters for accuracy in those minutes that anyone would like to raise?
Yeah, just to say that I've spotted a couple of typographical errors that need to be amended, so we'll make sure they're done.
Lovely. So some typos. And any matters arising from those minutes that don't appear later on our agenda? Nothing in there. Let me just have a quick look at the actions. So we have got actions at the end of the minutes. The first one is our response letter to following the verdict of Lucy Letby. And that's complete, I think, isn't it now?
It is, Chair. The updated wording for the Constitution was received and approved at the December board.
Okay, lovely. Okay, so that drops off. The freedom to speak up, that we have a 6-monthly report, and that will be you in May, Nigel. So May 2024, so that's complete. And finance and performance, an updated finance report provided to us at our December meeting.
It was, yeah.
Great, thank you. Okay, so as a rule, we would now move into the board assurance framework. But I think before we even do that, why don't we ask please, for Brent and Beverly to share with us progress around their recent CQC report. I don't know, Teresa, do you want to say anything in introduction for this item?
Well, firstly, thank you, Brent and Beverly, for joining us today. We've had a discussion previously at the board because I normally just present information from the CQC reports and our providers in quality improvement group status. But actually, there's nothing like bringing it to life with the people who are living and breathing this every day. So we started, I think, with Simon and York when they received their last CQC report, getting the Chief Exec and Executive team to actually present this on behalf of the board. So Brent's following in Simon's footsteps, and actually, as I say, I think it brings a richer depth to the discussion that we can have. And, you know, actually, as we will hear, particularly the tube demonstrates progress that is worthy of note.
Thank you.
And in addition, it's really great to have you in the boardroom with us. We're always pleased to see you and interested in your organisation. So, shall we hand over to you, Brent?
Yep, thank you very
Thanks,
much.
Teresa.
And thanks for having us this morning. Still this morning, I think. I did actually come, probably, it's over a year ago now, isn't it? When we were partway through, I think, our improvement journey. We still are on that journey and very much have a significant road in front of us. But I think it is good for us to be able to come along, I think, today to report on the inspection that took place last summer and the report that was issued at the end of October. And just, I think, describe some of the things that have come about as a result of that. Last time I did attend the board, I think there was a lot of familiar faces from around that time. It was virtually. There were obviously some difficult things that we were dealing with, and some of them are now quite historic, but actually they're still on our agenda. So the board will continue to hear a little bit about prosecutions and in difficult inquests and various other aspects of some of those historical issues still playing through our narrative. But actually, we think it's really important that we take the opportunity to talk about the work that we've done since those events happened, and that we, reflect a little bit on the hard work of all of our colleagues and all of our friends and partners in the system in supporting us on this journey to get us to this point. So I'm going to ask Beverly just to run us through the presentation, which is on the screen, and we shared in advance. By all means, let's have a conversation and any questions if we've got time to.
Thank you.
So thank you.
Thank you, Brent. I'm going to go through this at quite some pace because I think the conversation is the important part, isn't it? Next slide, please. So what this first slide is telling you is the scope of the inspection, and you can see that the CQC visited a lot of specialties, and in all, I think that adds up to 64 teams. So it was a really wide inspection across the vast majority of our services, and services such as the community mental health services for adults, and you'll recognise it in a mental health trust. That's a big part of the care that we deliver on any given day. The next slide will show you where we sat prior to this inspection, so we can see that there's quite a bit of variance in the quality of the ratings of the services. Some areas where we had issues that we needed to address at pace, but too much variance for the people that use our services to be confident of the quality of care. As we move forward then to the next slide, what you see is the difference between pre-inspection and the outcome of 2023 inspection. So on the right-hand side, you can see that the majority of our services can now demonstrate good quality that they're providing on a day-to-day basis. You will note, of course, that in the safe domain, we've got work to do. And I'll comment on that as we go through, because we understand entirely the issues, the strategic issues that we need to address as a board that are going to bring the difference to the safety of care for people who use our services. Next slide, please. So what this slide does is it gives you a summary of the changes overall. So overall, there were 3 core services that improved up to a good rating, which we're absolutely delighted about. 3 services that remained the same. And there were 12 domains across the core services inspected that it had improved, 15 which remained the same. And of those, 10 are good and 3 where we've seen a rating change, a rating decrease in a domain of a care service. Next slide, please. Really important summary here, because 7 out of the 11 of our services are now rated good. So we're really pleased for the public that they can see that our services in the main are seen by our regulators to be good services. And that all of the services are rated good for caring, absolutely fundamental. And that 9 of the 11 services were rated good or outstanding for effective. And what I often say when I give this presentation is it's all very well, isn't it, being caring and good and kind, but actually unless you're being effective, you know, so it's absolutely fantastic that we're good and effective in our services. Really importantly, that bottom line there isn't any domains in our services that are rated inadequate. Now, I understand that you might kind of question, well, you know, you're measuring yourself against a low bar, but we've also seen, haven't we, coming out of COVID, that many mental health services have seen some reductions in some domains in their care. So we're absolutely delighted that we've demonstrated an improvement in all those really important areas where we wanted to get to a different position. Next slide, please. This tells you some of the top line notes about where we've had positive feedback from the CQC. And what I like to do is bring together a little kind of subgroup of those. So if you consider that what the CQC found and reported, that we've got a clear vision and strategic direction that our staff understood, and that our staff demonstrated our values, and they could see, the CQC could see the positive changes in our culture, and that we're working in a person-centred way. If you take that little subset together, I would suggest to you that we've got the foundations to keep on moving forward and keep on improving the care that we provide, because those things are absolutely fundamental. On to the next slide, please. Areas that we have to improve that are absolutely crucial, other foundation issues around our serious incident process. And as a board, you are probably aware that we have been reporting a historical backlog of serious incident reports that needed completion. I can tell you that of that historical backlog, which at their most poor position were 174, we now have 30 reports that still need to be submitted to the ICS. And of that 30, 11 of them have been through all of our internal processes and have just been proofread. So we're down to the last 19, and we've got a sustainability plan in place to ensure that moving forward that business as usual doesn't start to represent a next backlog. Worth noting, of course, that we will be implementing PSERF on the 29th of January. We're in January, not July.
January, yeah.
And that's been signed off by both of the ICSs that we work with. Duty of candour, we know we had an issue with, and we've done a huge amount of work around that. And common with many NHS and particularly mental health trusts, staffing, having the right staff in the right place with the right training and supervision. We've absolutely got to get that right. We've got some fairly impressive stats around the numbers of nurses, registered nurses that we've got in post now compared to the same time last year, and we've been very fortunate in that we've been able to hold on to many of the registered nurses who've been in training with us at our local universities, both in the September cohort just finished, just concluded, and now in January we've got another big cohort. We've also managed to recruit 48 international recruits, and that's made a big difference, and obviously that has an impact on agency spend, which is important to us all. We know we've got issues around waiting times, and we did have issues with complaints. I think if the CQC were to inspect today, they would find that our complaints were in quite a different position. And physical health monitoring, which again for any mental health service is really important. Helen Day, who I think works quite closely with some colleagues in the ICS, has been working on our physical healthcare plan and making sure that we've got really good relationships across organisations, across boundaries, so that our strategic approach together means that people get the physical healthcare that they need. Next slide, please. This is a summary of the must and should do actions, and just looking at that must list. Wards for older people with mental health problems. Now that's a specialty that's rated good for us. They only attracted one must do, and that's in the area that I've been talking about in terms of staffing. So we're really, really proud of that service. We're proud of all of our services, but to have an inspection of that size and scope, that's pretty impressive. And similarly, if I just pick out the community-based mental health services for adults of a working age, given again the scope of those services across Durham, Darlington, North Yorkshire, Middlesbrough, York, and lots of other areas I'm probably forgetting right now. Given the scope of that inspection and the amount of people that we serve, to have only 2 must-do actions, that's impressive. So we're targeting those to make sure that we can bring those services to where we need them to be. So the next slide is a summary that tells you that CQC recognise the significant improvements that we've made. We absolutely know we've got work to do, and we need to ensure, as a chief nurse, I need to ensure that the prosecution ahead of us doesn't overshadow the really positive work that our staff have delivered over a prolonged period and in very difficult circumstances. We know that our strategy and our leadership is right, and we're absolutely delighted that it's the patients and carers that reported to the CQC the progress that we've been making. A number of those bullet points are things that I've commented on during the presentation, so I won't say too much other than to pick out the bottom bullet point, which is absolutely we've made progress and we are committed to moving further. We want to see our trust rated as good and moving towards outstanding, and we believe that we've got the values in the workforce and the direction, the leadership to be able to achieve that. I won't say very much more than that, other than to say we have submitted our improvement plan to the CQC. I think at the point these slides were submitted, we hadn't quite done that. So we have submitted that. The CQC have reported to our quality board that they are satisfied that our improvement plan will address the areas. And I think the remainder of the plan, after the next slide, gives you a full set of the must and should do actions just for transparency. I'll leave it there.
Yeah, just to round off, Sue, if I may, it has been a fairly significant piece of work for us to, I guess, get to this position. We recognise that requires improvement is not what we would have aspired for in this inspection, but actually looking at the consistency of what we're doing across those core services now and the improvements that we've made, I think, as Beverly says, we've got a good foundation. There are some specifics there that, again, Beverly's highlighted that we're getting on top of, which I think would put us in a much better position, come the next time that they visit us. The big focus for us is obviously with our overall delivery plan. We've got lots going on from a transformation perspective, which again, partners in this room are heavily involved with. Community services being the key focus of that, and that's where we need to be focusing our energy going forward. Making sure that we're embedding patient safety and quality as part of that overall approach. So we'll leave it there, Sue, and by all means, anything that anybody wants to pick up with us.
Thank you so much for coming. We appreciate that. It's great to see you face to face. I'm going to open this up to the board now for any questions, anything anyone would like to know more about. So I'm going to Stuart first.
Thank you for that. Enjoyed that and well done, because that looks like great improvement to me. I've got 2 questions. I'd like to understand more about the duty of candour and what you did to get improvements in that area, and then your staffing and staff retention that you've mentioned. That must help. Again, I'd kind of like, it's a sort of, have you learnt anything that we can apply in other places type question. So those are the 2 questions.
Do you want to go with duty of candour?
Yeah, so with the duty of candour, if you consider that we had a backlog of historical reports, you can see that there'll be a relationship between completing reports and demonstrating to families what we've learnt and being open and honest with them about that. So there was a clear relationship there. So we went back through every single incident that we had open and made sure that we wrote to those families, gave them a clear position statement about where we were with the investigations, and kept in touch with them. We increased our family liaison officer capacity by 100%. And made sure that families had named persons. I actually wrote named people to link up with, and I wrote to many of those families myself as an incoming chief nurse. It was an opportunity. To make the improvements, we worked with our North East North Cumbria ICB to make sure that we had a policy that was modelled on national best practice. We audited what our compliance had been. We've invested in further audits going forward. We have opened part of our website up as a microsite for staff so that they can really understand duty of candour, and they've got a suite of resources that's available to them to help them understand it. And the patient safety team, alongside of the complaints team, have taken a really proactive approach to engaging with families. We have ensured that we have engaged with families who have experienced the most harm done to one of their relatives, to be sure that we're being absolutely transparent with families.
On staff retention, we, as you may have picked up, we've got one of the lowest turnover rates. I think we're in the top 10 or bottom 10, whichever way you want to describe that in terms of turnover within the NHS in England. And we've seen a number of things really, I think, influencing that. I think some of it is really about our broad approach around culture. So lots of work that we've done around values and listening and putting opportunities in for colleagues to raise concerns through, obviously, the obvious routes through freedom to speak up, but other opportunities as well. We've done some practical steps. Obviously, we've got the various staff forums where, again, people can put their perspectives forward and so on. But we've implemented things like opportunities for people who are thinking of leaving to put their hand up, either in an anonymous way or come up front and have a conversation with us around what that's about, so that we can, I guess, think about whether there's something systemic there that we need to take into account, or there's something from an individual personal development, if there's an opportunity for somebody to be redeployed. The other aspect is about internal transfers as well. So we do have an internal transfer scheme, which looks to shorten the process around that. But again, where people are interested in moving, just want to change, and they can put their hand up and do that without having to think about leaving the organisation. There are a number of steps really we've taken on that side of things. And unlike a lot of organisations, we've learned a lot on the back of COVID around staff wellbeing. And some of the stuff that we've been doing there, which is really important. So, obviously we've got, salary sacrifice schemes and various other things that we've been doing, but we've just launched the Tuve 10K just after Christmas. So we're organising a 10K fund run, which will raise hopefully a bit of money for our charitable funds, but it's something which is generating a bit of
10K sounds more of a punishment than anything.
Well, it's not compulsory, Stuart. So but
Other than for the chief executive.
Well, exactly. I'll be there. But, yeah. But these are the sorts of things that generate a bit of buzz around the organisation. Close Facebook groups. That's those sorts of things. I think really are starting to create a sense of people re-identifying with the organisation, feeling a bit of connection with our purpose. As well as some of the practical things that we've been doing, like again, thinking about rostering and making sure that we're, making each shift, safe, that we're not moving people unnecessarily, where we've had pressures on staffing. Some of the feedback that we were getting, that people were getting fed up because they were being asked to move to another ward. We're making sure that we're doing that in a much more controlled way within a certain pathway, so they're not getting the keys to a ward they'd never visited before.
And your geography is quite a big geography.
Yeah. Yeah.
Could I just add to that?
Yeah.
So on the point of geography and linking back to everything that Brent has said, we've really invested, speaking as the chief nurse, we've really invested in the professional and nursing leadership. So although we're a large organisation, we've got care group directors of nursing and associate directors of nursing and matrons who've got a very good, as in positive, span of duty. So our matrons only have 2 wards. So you've got that really local leadership and those good relationships, which, when nurses are struggling and getting fed up, it's really important.
Tiny detail. How many 2 wards? How many staff does that mean a matrons?
So I suppose you'd be looking at about 70 staff.
Yeah, 30 to 35 per ward.
Yeah.
Thank you.
Amanda.
Yeah, thank you. Brent, Beverly, thank you very much for taking us through that. And I've worked alongside Tuve for a number of years now and really recognise the progress that you've made. Just on another note relating to the staff and the commitment and purpose, I had the chance to visit Foss Park before Christmas and I spent about 3 hours with teams and was privileged to have sort of genuine one-on-one conversations with a number of staff, and without exception the understanding and the ethos that came from those staff around the commitment to the purpose and the patients in front of them and that I witnessed was just, you know, it was incredible. And in a very challenged working environment with people who are in great need often, it was a superb experience. And if you've not been, I would take the chance to go. So I just think what we're hearing, I actually had the opportunity, albeit in a short period of time, to observe in York. So it was really grateful for the chance to go.
Thank you for that.
Thank you. Any further questions? Peter, yeah, sorry.
Thanks, mate. I was interested in the focus on diversity of your trust board in the inspection. Anything we might want to reflect on here?
Let's have a look around the table. I mean, you know, I think we've all got challenges, I think, haven't we, with diversity in this part of the world and in representation at senior levels within our organisation. It is a focus, I think, for us as an organisation, thinking about if you're a BME member of staff, you're more likely to be paid under a band 4 or a doctor. So, you know, we are doing all we can to think about through some of our leadership development work, that getting some of that breadth and depth of diversity across what we're doing. You know, I think it's something that probably we would want to work with as a system, to think about how we are, you know, attracting people from a variety of different perspectives and backgrounds and working through. So I wouldn't come along and advise anyone on this. We've all got lots more to do in it, and I think it is something of a shared endeavour, and I know that Jane and others through the workforce approach really are giving that some consideration.
Thank you. Jane?
Yeah, I was just going to add that when we have been doing the retention work across across the system, you've described already the majority of, there's 4 key levers that people have described to us. One of them that you haven't really mentioned, but I think is fundamental to what you've been doing, is the work that you've put into leadership and the compassionate leadership. And that is so important right through your organisation. So I think you should be proud of that and reflect on that, really.
No, thank you. And if I may, Sue, we're launching a leadership academy this coming April. And as part of that thinking, really, it's about some of that consistency across the organisation. There's an emphasis on not just leadership but management, because I think consistency actually relies on people applying themselves to some of our policies, procedures, the technique of leading and managing on a day-to-day basis being really critical to what we do. So, you know, we're looking at opportunities for people in their first level leadership roles right the way through to the board and beyond into the system. So an exciting development, but the compassionate approach is something that we've been working at for a long time. It's clearly based on trauma-informed thinking as well, which is obviously something I know that the system here has been looking at as well. So yeah, absolutely a key factor.
And to link to that, we've got our most recent staff survey results, which are, of course, at the moment, we've only got the very high-level messages, but I think there's some positive news in there that links very much to that compassionate leadership.
I'm very attracted to that. Stephen and I have been talking about our year ahead over the course of the last few weeks, and we've been talking about the disciplines of leadership, so the things that leaders do, and just do every day, a bit like
habits of, practice of.
So your leadership academy sounds most interesting in that way. We might be asking you a bit about that.
By all means.
Jane?
Could you describe, do you have a quality, I think you have a quality improvement system. What is the system that you deploy in your organisation?
Yeah, we do. Jane, have a quality improvement system. It's got quite a legacy, and I think you probably would recognise aspects of it from your previous role and previous manager. It was based on the Virginia Mason approach, which is obviously a lean system. We've been at it in various guises since the late 2000s. So it is very well embedded, and we've got quite a depth and breadth of skill and training across the trust. We've kind of shifted a little bit in the philosophy around it. We've augmented it with a solution-focused coaching framework called Think On. So part of the challenge around the lean methodology is it's very process-driven, and actually we were missing the connection with the people aspects. So bringing it together with a coaching framework, we've got a bit of a stronger package which resonates with people on a day-to-day basis. And where we're trying to get to with that is that individual practitioners and teams are changing their own work on a day-to-day basis using those sorts of techniques and methodologies.
Thank you, thank you.
And if I may, sitting alongside of that, we've also got a really good approach to quality assurance,
Yeah.
both through our integrated performance report that the board receives and also the qualitative measures that we take routinely, where we know we've had issues, and what we're likely to do, where the integrated performance report or the quality assurance schedule is telling us practice is not where it needs to be, is we'll draw in the QI rather than necessarily take a straightforward management approach.
And that's the move from QA to QM, quality management. So that's the approach we're taking.
It sounds really good, thank you, thank you.
Teresa, Michelle, Stephen, and then we're done.
Okay, thanks. Just one thing to pick up on. I was just curious, there's not a lot in the presentation about the wider engagement. I know the duty of candour, but the wider engagement that I think you've done some work around, both in terms of listening to the voice of your patients, but also, you know, wider with the public as well.
Yeah, absolutely. Co-creation is something that runs through the strategy. And we've taken a number of different steps towards this. We've very much moved to get the voice of lived experience within some of our leadership structures. So we've appointed lived experience directors to our care groups. So they're embedded from a governance perspective, a decision-making perspective, assurance, as well as service development and moving things forward from a service design point of view. Try to replicate that at different levels within the structures as well, and certainly from a peer worker perspective on the front line, we're growing our numbers there, and we've got plans to do more of that, as I know with us around the table will be doing as well out there. You know, the overall co-creation work is now governed by a framework that we've developed. We've got about 400 active involvement members that are involved in various different aspects of work that we do through service improvement, design, you know, where we've got issues that we're, you know, looking at from a quality development perspective and those sorts of things. And that's, again, you know, a critical part of how we do that work. I don't know whether you would add anything from a co-creation perspective.
Well, just to say that we've also appointed and is now in post our lived experience, not lived experience, our lived experience director. So we've got the lived experience directors and the co-creation directors. So we've really invested in that part of the work. And again, I think if the CQC were to come today, because what we were talking to the CQC back in March, April, May about was what was ahead. But now if you were to come into our services and see the way that we're working and making changes and being held to account, importantly, you'd see it live.
Thank you. Michelle?
No, just thank you for the presentation. It was great, and circulating the papers and a great presentation. And actually, I suppose I would say this working, so it's really good to see. It's really difficult to shift CQC ratings. It takes a long time, and I think it's really positive to see that, because I appreciate firsthand the work that goes into doing that and to maintain the stability. But especially important for me, because people around the table know I'm absolutely obsessed with culture. It's really, really pleasing to hear about everything's been sort of built on that architecture of culture, because if we don't get that fundamental thing right, it doesn't matter about anything else. So that's really came through, but really sort of very positive to see. So obviously, as always, happy to continue to help out and around. But thank you.
Thank you, Michelle.
And finally, Stephen.
Yeah, I just had a question. And by the way, thank you. It was a great presentation, really clear. So thanks very much for that. And then a comment. But just going back to the, understanding the map of CQC ratings. You're very close, actually, to being good. You need to change 2 or 3 of those ambers to greens on the safety side, and that's clearly, and you did flag that quite clearly. So I'm just interested in and it maybe relates, Beverly, to what you just said, because obviously that was a point in time, because that's the final step, isn't it? To maintain what you've got already there, but then to improve that safety domain. So can you just say a little bit more about what you're doing there, and then I'll come to my final comment.
So there's a very small number of things that will make a big difference. The one, of course, has to be managing our learning around when things go wrong, so serious incidents, complaints and so on. I'm really confident that we're in a different place and PSERF will take us forward again.
Yeah.
So that's absolutely key. And we were cited on that prior to the CQC coming in. The second that will really unlock things is making sure that we've got teams that have got sufficient, qualified, well-skilled, trained and supervised staff. So it's the numbers of staff, the type of staff, mandatory and statutory training, and also supervision. And then there was one or two things to change around our governance to make sure that we had really good floor-to-board oversight of one or two key metrics. That will make a huge difference. That will unlock our potential.
Thanks. So my comment, there's two parts to this. First of all, I think from the, if you like, the technical point of view of having these sessions, I would feel, and question for the board, I suppose, that we can get a significant degree of assurance about this progress from what you've presented to us and what's changed in the last 2 years. And you've given us some insights. Amanda mentioned some more direct experience recently into what's happened since. So I think I would take away from this conversation a very positive vibe, really, about assurance for us. But my last comment is just, I mean, you know, I've sort of been on this journey with you, Brent, from afar, in the spirit of support. I mean, I think what's really, impressive in that list earlier is the things you were putting together about clear vision, that people understand, the impact of leadership. And I know that's been a fairly tough journey to get to here. So I just want to acknowledge that. I mean, those two things, obviously, the assurance and the strength of leadership sit together. So I just wanted to say those things as we bring this to a conclusion, Chair.
Thanks very much.
Yeah, well said, Stephen. Thank you. Thank you both so much for coming along. You're more than welcome to stay. We would quite understand if you wanted to leave.
Thank you.
Great. We wish you a happy new year.
And to you.
Thank you.
And by the way, if it could suit, if people from the board want to come and visit any of our services, then by all means the doors are always open. So
yes, I think
let's
it's
arrange
time I
that.
did that again.
Yeah.
Thank you.
Thank you.
Thank you.
Thanks.
Thank you.
Thanks, Sue. Good to see you. See you later.
Now we've got 2 spare seats at the head of the table. Can I just ask perhaps Jason and Michelle to move around a bit? It's very hard for me to see you where you are. It's very helpful to me to have a closed loop on the table so I can see people more easily. Thank you. Irritating as it might be to ask you. Helps me enormously. There we are. I don't miss you when you put your hands up now. Shall we revert back to the agenda as we once knew it? Let's go please to item number 7. This is the paper in which we review our board assurance framework, reminding you, those who are newer to the board, that the board assurance framework seeks to pull out those things which represent the greatest risk to the achievement of our strategic objectives. So we seek to identify those risks for the board, and we need to understand those mitigations, and then we rate them. So this is the board assurance framework in respect of the greatest risks that we see to the board. And for this item, I'm going to hand over to Karine.
Thank you, Chair. So I will take most of the report as read, but just to point out a couple of specific updates for the board. So under the strategic objective of managing today and in relation to performance standards, the board will remember that at the December meeting we received a new version of this risk. Well, it was an introduction of this risk onto the board assurance framework. Following that conversation, we've just adjusted the risk description as set out in the paper, and there are some mitigating actions that have all been updated in relation to that. Under our strategic objective of managing tomorrow, under risk reference B2, which is the relationship with partners and stakeholders, there are a number of mitigating actions that have been completed and moved to positive insurance. I think We'll hear more about the Futures Group at our next meeting, but they have been doing some great work, and also some of the work that we've been doing with our local authority colleagues around the wider determinants piece. And our place directors as well have been involved in that. And then finally, under enabling the effective operation of the organisation, we had a long conversation, a bit of a dive into some of our effectiveness to engage on our legal duty to involve patients. So there's been a few revisions to that risk as described in the paper, and also in terms of our governance processes and effective control mechanisms, which is risk reference C2. There is some updates there in relation to the delivery of some of the reports that we will be doing during Q4 of this financial year. The other thing just to note for the board, we do a regular comparison against the corporate risk register to ensure what is sort of sitting as out of appetite or as core themes on the corporate risk register through the executive committee, and we looked at all of that collectively and have nothing further to identify to the board that isn't already captured within the board assurance framework. So that's everything, Chair.
Thank you, Karina. Any questions for Karina regarding the board assurance framework? Anything you think we might be missing on there? Anything that has come to your attention when you were reading the board papers? Do you think we've got that right? Yes, Richard.
It was just, I guess we may come on to it when we talk about some of the digital work. There were some comments in that paper about being realistic in our digital risks. Are we capturing those in the right way? Have we got the right ones on there? And that's perhaps something that we can reflect on when we talk later on your paper.
Yeah. Okay. We accept that. I wondered about anything in relation to mental health, actually, as far as the BAF's concerned. But again, that might emerge as we go on today. Thank you, Karina. Let's move to item 8. Item 8 is around the voice of lived experience. You'll know that we've been driving a real campaign to make sure that this board hears from those people that we serve as best we possibly can, and that we connect our decision making and our thinking to the way in which we know people experience the services we offer. Anya has been at the forefront of this work, and it's has developed ahead of steam over the course of the year. So I'm really pleased to welcome this piece to board, but I think that we'll be delving even further into the voice of lived experience as the year goes on. And in some ways that plays a little bit to Peter's cheeky challenge to Brent around diversity at board. How do we get to hear some slightly different voices at this boardroom table? So to you, Anya.
Thank you, Chair. So this month we have got the dashboard, which is a snapshot of the work that has happened over the last couple of months. So I will take these slides as read, but I will just pull out a few key points if that's okay. As the paper or the deck sets out, a lot of work has been focused particularly around the Humber Acute Services consultation and the review of the engagement that was undertaken in respect of the proposals to close the walk-in centre in Story Street in Hull and open the UTC at the Hull Royal Infirmary site. And so, as you can imagine, because of the context in which that engagement has happened, there are particular themes that have come out, and those are documented within this report. But what we were hearing from those conversations are that access continues to be a key concern amongst residents, as you would expect, but particularly in the context of service change and service development. A lot of issues raised in terms of physical access to services, and particularly access to transport to get to those services and the cost associated with transport to those services. And I'll come on to that in a little more detail in a second. There is a concern amongst many of our residents about the development or moving of services leading to further challenges within our hospitals. But as we've touched on before, again, the context for this is that most people don't fully understand how our system and how our hospitals work in the first place. So this is based on a preconception, if you like, of what they think happens in a hospital. But there is a concern, if you like, raised that things like REDs will become busier, that we will have further demand for beds, etc., as a result of some of these services. And of course, that's a key part of the engagement work, that we can actually talk through what is involved in these proposals and actually help to give a more accurate picture of how our system works and how those the changes that we're proposing will ease or improve some of the way services are delivered. And there is a sort of residual feeling amongst many parts of our community that there is a lot of change happening at once and that they're losing local services. It links back to the first point around access. Of course, most people want to access services as close to home as possible. So if they feel they're losing that and that this potentially is the tip of an iceberg, that generates a sense of concern, and as we've documented here, a sense of this is just the start. And of course it may well be, because we do need to make further changes, and again that is part of the conversation that we have in terms of the engagement and indeed in terms of the consultation that has been running. But if I just whip through some of the detail that you have in here, so firstly you've got a couple of slides in relation to the engagement with our patient networks, and we have over 2,000 members involved proactively in our patient networks, but we have pulled together over this period the first session that brings together our new patient engagement network covering the full ICB, and we had more than 70 attendees at that. Councillor Owen was one of the speakers, so there's a high level of engagement, which is really positive. And again, to stress that these are groups that are already fairly well engaged and fairly well interested, and it's really important that we keep that engagement going, thus why this programme of work is really important. And then there's just a focus on the next slide in terms of the Hull Champions programme, which is very successful within the Hull area, and again something that we are working to look at across the wider footprint. Chair, you touched on the Voice of the Lived Experience workshop and work stream that started earlier in the summer, and this is just, the next slide just provides an update for colleagues. Sorry, I think we've lost a slide somewhere there. Just provides an update in terms of the latest developments. So initially back in the summer, we had primarily members of teams within the ICB coming together to triangulate the work that was happening, the data and insight that is being developed, and that goes into the dashboard that I'm presenting today. The further workshop that happened was bringing in over 40 other internal and partner representatives to think about how we can expand that work. So that included colleagues from across the VCSE, from across our providers, from across our local authorities, with two main aims really. One, to look at how we can better map the work that is happening and planned so we create more efficiency, and then two, again, triangulating the data and insight and intelligence. And off the back of that, we have been developing what we're calling a sort of insight bank, which is a repository for all of this work. And again, the idea is that everything will be in that repository and any partner can access it, and it's getting quite intuitive. So as an example, you could have a look at concerns around residents living in rural areas in relation to accessing healthcare, and it'll pull up everything that relates to that topic that has happened through different partners. So it's a much more effective way of being able to surface the insight available. I can't move on the screen, I don't think, but I did just want to flag, and I think this builds on what we have talked about in previous board meetings, but particularly there has been some really, really helpful work that has happened over this period in terms of a face-to-face and virtual event taking place in York relating to adult autism and ADHD. Colleagues will be aware of some of the particular issues we've had. It's documented in the slide here that we've seen a significant number in referrals for assessment. So this was a deeper dive with members of the community that have an interest in this to really understand what matters to them, what are the issues that they're experiencing. And as you can see here, absolutely the main theme, and all of this is being more fully reviewed, and we'll be bringing a more comprehensive report. But there is a significant concern from members of the community about what they perceive is the lack of support, both pre and post diagnosis. And absolutely we got a feel from that community that there is a strong commitment of the benefits and the need for a diagnosis, and that is obviously a key concern for that group of people. But it was very helpful in terms of being able to have much more meaningful engagement with members of the community on that very important topic. And then we've just included a summary of the engagement that happened in respect of the walk-in centre and new UTC at Hull Royal Infirmary, which will open later this month. As I always say, any engagement or indeed consultation is not a referendum, but you can see from the outtakes here that more than half the respondents supported the development of the urgent treatment centre and being co-located at Hull Royal Infirmary site. A third of people were not in support, with the remainder undecided, but you can see there a number of the issues that were identified and covered, and in particular because the existing walk-in facility is located in Hull City Centre, a lot of that engagement work was really targeted at some of our more deprived communities and our communities where we have members of the public with protected characteristics, and there was a lot of work in terms of translation and meaningful engagement to make sure that there was the opportunity for those voices to be heard. And then finally, we will be bringing back the more comprehensive, well, the full report in respect of the Humber Acute Services consultation, but we have just highlighted the point in time themes that were coming through from the engagement through the consultation process. Again, similar issues around travel and access, and as you can see from the information that's presented here, a concern particularly from residents in Scunthorpe, a feeling of losing services, and again this being the start of further change to come, and a lot of concerns from residents in Goole, not related actually to the proposals in the Humber Acute Services consultation, but more a sense of what is happening at Goole Hospital and how do residents of Goole access services in a more meaningful way to them. And again, it goes back to that view of what they expect happens in a local hospital versus the reality of what now happens in a local hospital. So I hope that was helpful as a quick snapshot of the work that has happened most recently.
Yeah, really, really helpful. And yeah, I've long said we should make sure that we name things to reflect exactly what they are, hospitals in particular. So people become very attached to the concept of a hospital when in actual fact that hospital probably isn't delivering a full suite of hospital services in the way that people might, in their minds, imagine. I'm very keen on this strand of work. I'm very keen on the feedback that you've provided us with, and I'm very keen that we make sure that's integrated into all of our work. Mark?
Yeah, just to say, I was very interested to read this. We had a Health Watch presentation at the Quality Committee just before Christmas, and there's a lot of correlation with this. So I suppose my point is that was, it's not just in the Hull and North Inks patch, it was coming across elsewhere. And I think particularly the transport bit, and I was left with the question in my head, do our patients and service users kind of appreciate some of the options available to them in terms of transport that, for example, voluntary sector and so on. But I kind of just float that out there, but it was nice to see the triangulation, and I think it's really important stuff.
Great, thank you, Mark. Jason and then Louise.
So just a few things. I mean, the transport one I think is really important because we are holding the first kind of community transport roundtable. I think it's the end of this month or middle of this month, and part of that is about understanding that the clinical transport to get to and from hospital is kind of quite big infrastructure around it. Actually, transport to get people to and from hospitals to visit people, or or discharge from hospital, is a bit where there is real shakiness in terms of variability around it. So I think we want to start out to understand what exists at the moment in terms of community transport. What is the option, and actually what's the investment that we need to make? And actually, it's quite a complex area because I've heard quite a lot around the transport stuff from people saying, it's all very well being able to get to a hospital, but actually if you're wanting me to go and do some day activities somewhere, I don't have the ability to have transport to get to day activities in particularly rural areas. So North Yorkshire and East Riding in particular kind of talked about it. So we should have some stuff coming out of that workshop, although I've been really clear that we're not going to solve it overnight, and actually there is a financial cost involved in the whole transport thing. But transport clearly, even in urban centres, is really important. So the availability of a bus that gets you to somewhere at a reasonable time, you take a risk, don't you, that you're going to miss an appointment because you won't do it. There was just a couple of things. So one of the ones for me was around, I think it goes back to, your point, Sue, which is around people's understanding of hospitals. So it goes back to my whole bit around the nature now of health and social care is different to when I was kind of growing up, where hospitals were the place that you went to, you stayed there for a week, you got your hair done, you got good meals. And actually that whole concept of hospital should be the last resort, and actually, community services is really important. Actually, I don't think we probably had the dialogue with the public to say hospitals are changing. So what you think it isn't what it was 10 years, 15 years ago. So it kind of goes back to that whole dialogue, that narrative that says there's a range of different services which aren't a hospital, but it's going to be the right service for you. And it's about how we build that into that. We've talked about it in terms of primary care, but I think it's the same for secondary. And then the other bit I'm really interested in, and that whole bit around engagement, around PPGs and primary care. And I think there was just something for me about just trying to get an understanding of patient participation groups. Actually, are they effective in terms of primary care? Do they actually capture the voices of patients? Because actually they're really valuable in terms of our primary care development. They're really valuable. But I'm not sure whether or not we've invested enough in developing a really different infrastructure, because what strikes me about patient participation groups, and having been bruised by them numerous times, chairing a primary care committee, is they tend to be groups of people who are regular attendees and kind of see the poster, but actually there's an opportunity for me around those people who don't get to see the doctor need to have a voice as well. So is there an opportunity as an ICB to almost rethink what patient participation groups look like? Are we embracing digital around it? Are we really capturing some kind of different voices? Because actually, if we do that, I think we've got a really good mechanism to talk about primary care development. And at the moment, I think we have something that satisfies the CQC box, but actually whether or not it's the effective mechanism you want it to be. So I'm interested in knowing more about PPGs, because I think we're probably not doing as much as we should be.
Thank you. Louise, and then Andrew.
Thank you, great report, thank you. I always find it really interesting. It's so important, the voice of people with lived experience in the work that we do. But just to plug for the...
Can I just check Louise has got a microphone in front of her so she can be heard?
I've got two now.
Oh my God.
So did the plugs.
I'll just continue. Okay. Yeah, just in terms of the issue around autism, we do have the autism strategy out to consultation for North Yorkshire at the moment, so it's a bit of a plug to make sure that board are aware of that, that people are encouraged to take the survey and also to join in on the groups that we've got around the county. It really does build into that slide that Andy has put into the slide deck.
Okay, thank you. Andrew?
I just think it was that point, just build on the point that Jason's raised as well, is that maybe sometimes what we need to do is as well, and maybe something is in your strategy, and Jane, I've missed it, but is around, I think it's what we talked about earlier, which was in the previous meeting about the changing face of illness within communities and personal illness and multiple morbidities and what that actually means.
primary care and in the ICS, in the ICB as well, huge amounts of work. I think it's important to say that we've learned and reflected on the periods of industrial action that we've had through the year, and I think some of the success that we've had has been around the system working together, predominantly to support patients, but also importantly to support our staff, because the front door of ED is one of the most challenging environments to work in, and then that causes problems throughout the whole system. So a real focus on keeping patients and staff safe. And there's around the industrial action, particularly notwithstanding the winter plan and the winter preparation, we do a huge amount of preparatory work across the hospitals and community to support that flow and keep patients safe and ensuring they reach the right treatment, but also an absolute focus on ensuring patient safety during the period of industrial action, and that is almost the number one thing. And I'm pleased that we had no instance of safety issues that we needed to report or escalate over the period, and again that's testament to the significant work of the system. There was also a renewed focus pre-Christmas on delays in terms of ambulance handovers, and we have had some challenges in terms of delays, but we've been doing a lot of work across the system with partners around the hospitals particularly to focus on that, and we have improved that performance. But there was also a lot of focus on that, so that again created a lot of work for teams in terms of the reporting requirements around that, but we have complied with all of those pieces of work. So during the period and now at the second week, as Stephen said, we've actually seen performance being fairly stable, a better position than we would have hoped for. The 4-hour target fairly stable, and coming out into January, and so almost on plan. We're obviously in a recovery plan position, and we've still got an ambition to reach the performance by the end of March. And we continue now that we've moved out of this period of industrial action to focus on the delivery of all of the actions in the urgent emergency care system improvement plan, which are both local actions with trusts and community providers and primary care, and then at scale, and where we can systematise and do things once. And I think it's fair to say that there's a particular piece of work moving forward that we want to get into with our partners in both of our ambulance services around building on some of the good work in terms of handovers. So I think that's all I wanted to flag. Thank you.
Any questions for Amanda? Stephen?
I'm finished, yes.
And anything further for Stephen? Teresa, then it really is you.
Okay, thank you. Okay, so the first thing is the report of the meeting of the Quality Committee, and this is the meeting that was held on the 26th of October. We've obviously had some discussion at the private board in December in relation to some of the items on this report, but we do need to ensure that the board has the formal report from the committee. So I'll take the report as read. Just a couple of points to focus on. Firstly, that we maintain the deep dive focus on maternity issues, and at this meeting there was the focus on the 3-year delivery plan, but also in relation to the review of governance, risk escalation and engagement, which was again reported back to the board previously, which is about refocusing the LMNS to make sure that there is a dual focus around assurance and improvement. The work of PSERF, we've already heard from Tuve today, their plans have been signed off, so we are on target to deliver in full the PSERF implementation plan on time. In terms of the board assurance framework and the policies that are detailed and the quality assurance and improvement framework, they have all been to the board previously, so I won't dwell on those. The final thing I want to say relates firstly to the Health Watch update. So again, as you pointed out in relation to the meeting held just before Christmas, there is a real resonance in terms of the feedback that we're getting via Health Watch and the
a voice of lived experience that Anya has just taken the board through. And finally, again, because we've heard from Tuve this morning, just to remind everybody that the ongoing process of quality assurance processes in the background that allow us to do the deep dive and support improvement work is the quality improvement groups. And it takes a long time. It's not, we have a couple of quality improvement groups and everything's sorted. As you've heard, in Tuve's case, it's taken a couple of years, and that's what we expect to see in terms of the quality improvement groups. So I'll leave that there unless there's any questions.
Anything for Heather? Not Heather. Well, I was looking on at the next agenda item, and that's Heather's written it, hasn't she?
She has.
Anything further for Teresa? Yes, Louise?
Yeah, just to say, I'm pleased to see the inclusion of public health data to triangulate with all of the work of the quality groups. So I'm pleased to see that. Thanks, Teresa.
Yeah. Okay, thanks, Teresa. Okay. And now, moving on?
Yes, so this is now the maternity investment standard and the previously known the clinical negligence schemes for trusts. It's year 5 of this scheme. And really this paper just provides a progress update because the submission deadline is the 1st of February. And that deadline is for trusts to submit a board validated return. So the paper sets out the dates really that trust boards are reviewing their returns through January to ensure that they can make that submission by the 1st of February. And the LMNS have had an ongoing programme of work to provide assurance throughout the year, and there will be a final piece of assurance with providers prior to that submission. At the next board meeting, I'll bring back the detail so that the board can get that understanding of the assurance process and more detail in terms of the returns. But our position at this moment in time, we expect Harrogate and LAG to be reporting full compliance, and Huft and York and Scarborough to be reporting compliance for 7 out of the 10 criteria.
Is there an explanation for why some are compliant and some aren't?
We've touched on some of this in previous boards. Some of it was around training, particularly mandatory training. Some of it is also in relation to the fact that we've done some deep dives and a greater intensity of our assurance process in year and have identified things from previous years that have needed to be addressed. So, and that's the reference to the ongoing dialogue with NHS resolution, because we've had to, providers and ourselves have had to be in regular discussions with NHS resolution about how we address some of those historic issues.
Thank you.
So just to lift this slightly, I mean, not take anything away from what Therese has been saying. This is about risk, basically. Yeah. And so my question, and not to dwell on it here, is when we get the report back in February, will that tell us when the 2 trusts were not compliant, when they will be?
When they will be, it will.
Right,
yeah,
fine. Yeah. Okay, thanks.
And Jane?
There are financial implications associated with non-delivery. I think for Hull and Enlag it's about £800,000. I couldn't tell you what the York and Scarborough one is. It's similar, I think, because of the size, yeah.
So this is a new £800,000 that trust has to find?
Yeah, they'll lose, so that in their financial plan they assumed full compliance, and so it depends what they'd assumed in the plan, but most providers assume compliance. So that's been a challenge for Hull, and it will be part of the financial problem at York and Scarborough True as well.
And how quickly can a trust turn that round, Teresa?
So York and Scarborough declared non-compliance last year as well. So that was built in, that was an expectation. I think they've still encountered additional difficulties that have required discussion with NHS resolution. Huft declared compliance across a number of metrics that on closer examination and review of governance has led us to identify that they would not have been compliant, and therefore so that they will not have made an allowance for that.
Yeah.
And do you imagine this time next year they will be compliant?
That's the ambition.
Thank you for that. Now, for those of you that are keeping an eye on the clock also, you see it's just after 1, and we do have another half an hour to run with the board. So I'm going to suggest we keep going through the agenda until our agreed lunch break at 1:30. So just in case you're struggling to navigate the way we're working through this agenda, we're now on item number 12, and this is the clinical and professional update, and I'm going now to Dr. Wells.
Thank you, Chair. So we've produced 8 slides for you today, and I'm going to flip it around in a way and just quickly talk about medical retinal drugs. And of course this came to the Quality Committee that Teresa talked about as a policy to go through. And as you might remember, the background and position of this was that we need to make sure that we are using taxpayers' pound in the most efficient and effective way possible. And looking at the way that we use all medicines and all our technologies is really, really important. So what we're doing here is implementing a policy to look at the most cost-effective way of delivering services to our residents and our patients. And we are taking it through a number of groups and networks to start to implement this. And the couple of slides that we've got on here just talks about that. So if that's okay, I'll leave that there, but we will come back to board and update you on that. The main thing I was going to talk about, especially after the Christmas break, was maybe about everybody's cardiovascular risk. So I thought it was a good time. I thought it was a good time to
reminding us, Nigel.
Remind us. Yeah, to talk about that. And of course, we know that deaths from cardiovascular and cerebrovascular diseases are number one impact on death for us in our region. So it's really, really important. And the slides that we've given you here talk really around cardiovascular disease, and there are some abbreviations here. So cardiovascular disease is CVD, AF here is atrial fibrillation, and CKD is chronic kidney disease. So when I talk to patients that come in to talk to me about blood pressure, I'd say about, well, have you got central heating at home? And they normally say, yeah, I've got central heating at home. And I said, well, do you know what pressure it's running at? No. Okay. Do you think it's above pressure, normal pressure, under pressure? I don't know. Okay. What do you think would happen if it's over pressure? And we talk about, you don't know about that. Your heating's going fine, but at some point the boiler's going to pack up and your radiator's going to leak. So think about your radiators being your end organs, your kidneys, your heart, your brain. And think about your boiler or your pump being your heart. And at some point, if we don't know all of these, if we don't know our numbers, if we don't know what risk we're at, something's going to happen. So that's why we call it the silent killer, really, hypertension, isn't it? And so it's really, really important that we say to our residents and our colleagues and our family members, do you know your numbers? Do you know that your pulse is regular? Do you know what your blood pressure is? Do you know where you could actually go and get it checked and tested? And actually, the slides talk about 2 areas that we're really wanting to hone down on, which is if you do have hypertension, if we do know that you've got hypertension, are we treating you correctly? Because we know if we do, then we can have significant impacts to your life expectancy and how you're going to be in your life. And then the other one is about how we're also using lipid-lowering mechanisms to make sure that your cardiovascular risk is as low as possible if we know you've got high cholesterol. So those are the bits that we're really talking about here. And I suppose the other thing that comes really out with this, and I think Louise will want to maybe pick up on it, is that, of course, the most deprived communities have the biggest impact with this. So they're likely to be the ones that don't know their numbers, and they're likely to be the ones that maybe don't have the services that are in place to really get that impact that we really want. And what we've talked about on our last slide on this one is the programme update from the Cardiovascular Disease Prevention and Transformation Programme, which is really starting to hone in on data, looking at how we can really hone down on those coastal communities or those communities that we really want to talk to about that, and how we can also link in with local authority colleagues around the health checks, which of course sit within the local authority umbrella or under a local authority umbrella, but really need to be linked into this complete thing about how we go forward with our residents about knowing your numbers, understanding what we can all do to reduce our risks as we go forward. And it just shows about where we're at with that, and also the final point is around how we're thinking wider with our community pharmacy colleagues about getting blood pressure monitoring there, and even sort of independent prescribing pathfinder sites, and what we can do from an ICB level. So I don't know whether, Louise, if there's anything...
I think you've done a brilliant job there, Nigel, in describing it and bringing it to life, really, in terms of what we want people to think about. Needless to say, this is a top priority of the Population Health and Prevention Exec Committee, isn't it? And it's really pleasing to see that this work is co-chaired between Dr James Crick and Claire Beard, who's one of our public health consultants. So it really shows that kind of oversight and partnership working that we've got between us all. So that's really powerful. And of course, it links to our work around tobacco and the single preventable killer and health inequalities, and it links to primary prevention and all of the assets in place and in local government around moving more, keeping a healthy heart and making sure it's accessible to all of the population to do that, but where people need more support and help around reducing health inequalities, that they've got the means to do that and the support to do that. So thank you, Nigel. I think that's a super oversight of the work we're trying to do here.
Thank you. Thanks, Louise. Bushra, Stephen, Andrew.
Thank you, Nigel, for bringing this up. This is obviously something that exercises me a lot as a GP in my normal day job. I think one of the things that I would maybe mention is that these are things that were traditionally picked up by GPs who were seeing patients for a variety of different reasons. And as we find that access and demand become more of a focus, GPs particularly are seeing a smaller cohort of patients who have greater need, and some of the patients who maybe would have just passed through for something fairly simple aren't actually coming over the threshold of the practice in order to have their numbers checked and get to know. I think talking about how else they can find out is brilliant. So talking about community pharmacy, talking about NHS health checks as a kind of formal thing, but also thinking about how we can involve employers so that actually people are getting checked in their place of employment and knowing about their health, and if there is a problem, then being able to be directed back to the people who could help them with it.
And so many people wearing smartwatches like this that can take your blood pressure in a trice, aren't there?
Absolutely. So many people interested in knowing about it, but then still a cohort of people who would rather not know and rather not find another problem when they've got so much to deal with.
Thank you. Stephen, next.
Well, I was going to say that, that this is right at the heart of our overall mission, isn't it? In relation to improving quality of life, our 2030 deadline. And it's quite encouraging it's important, and just to highlight how important it is from this board's point of view. And it's quite encouraging where we are on the sort of metrics. I was thinking certainly on the one where we're doing better, I guess we'd want to push out to even better metrics on that, as well as getting as close or not beyond those on cholesterol management and so on. But I think, and I'm assuming, so I don't get to my question, I just wanted to highlight the importance of it, is I'm assuming we've got the infrastructure to drive this agenda. So if I'm thinking about tobacco control, I'm not worried about that because I'm really clear about where we're going with all of that. Do we have a similar infrastructure, or do we need to do more about that in order to drive this agenda harder? That's the question, really.
Well, this sits really within primary care general practice.
Wherever it sits, I did just
and it sits there at the minute. But whether we can give it even more focus, and I'm sure we can, and emphasis, we probably can. But that's where it sits, and that, in my view, is where it should sit as the overarching driver for it.
Andrew.
Yeah, thank you. it was just maybe not to lose sight. I know we talk about primary prevention, which is extremely important, and I've mentioned it before, but I think, Chair, there's something about not losing sight on the secondary prevention element, which is that actually, once you've treated this, how do you proactively keep people engaged in making sure that they continue to take the prescribed medication and that we have services that can pick up and support people with high blood pressure, just as one example, but also with high cholesterol and stuff. And it's really sad because we've had so many services that in this area we used to provide decommissioned through public health cutbacks that actually were about that both primary and secondary promotion. So in Hull we used to run community health checks in the city centre where we used to do automatic blood pressure stuff. It used to measure that, go into the record, that would be gone. Now we've run some successful stuff in Wigan and stuff like that where actually that is really popular with the public. And absolutely, if it's opposite a market, it's somewhere accessible, and it's about then that direct referral out into. But I really am concerned that we do lose I know we won't, but I think in some very deprived areas, one of the things is how do you keep some of that population that's at most at risk, keeping them into that regime that will stop them developing multiple more, as you say, you know, the leaks here and there that are going to cause us much more, because that's where the problem is. And the problem in the cohort is that we're that cohort that could get multiple morbidity if we don't look after this cohort population, because we are the ones that are going to be the 80, 70-year-olds that are going to be, we need to get down to one comorbidity, not multiple comorbidities, and we need to manage that one really well. So I think there's a double strand here, and I just think we could focus on prevention without actually thinking that prevention is secondary as well in a lot of respects, and there is an element of tertiary, which is that bit about actually intervention, but you don't want to get there. So actually...
So just a quick point to come back on. I mean, this is where this is so important, because I know you made the comment. I mean, I've got one on. You know, the people in these communities are not going to be doing this. I mean, a lot of people are, though, who will, in a sense, be adopting self-care, won't they, in relation to increasingly. So if you play back to our overarching aim, it is about how do you do what you're talking about for the most deprived communities, and the evidence is telling us that that's where we need to focus. So I suppose that's what I'm on about have we got the general practice is a big amorphous thing, and I'm not and I don't argue with that it shouldn't be, but have we got the right focus on that, and are we assured about that? And Anya, I think there's a massive connection with what are we doing then with our engagement resources about the sort of thing Andrew talks about, etc., about driving awareness on a regular continuing campaign. So just to throw those points in, it'd be useful, wouldn't it, to just get some understanding for us that we are on all of that.
Jane, Teresa and Jason. Oh, and Amanda.
Well, actually, my point was really similar to Bushra's. How do people get that level of knowledge around themselves or even their family members if they historically would have gone into the GP and then their access to GPs is more difficult? I mean, I'm 61, I've never had a NHS health check in my life, and I think there's meant to be a regular cycle, isn't there, of calling people for health checks, and so I have no idea, for example, what my cholesterol levels are or anything like that. So it is difficult. It's not working, I suppose, is what I would say from that point of view.
Well, we should look into that, Jane.
Well, I can look into it for myself, but there'll be lots of people like me, won't there?
For sure. Teresa.
Yeah, can I just pick up on this point, on this data, on this hypertension management? I just want to make sure of interpretation, because my interpretation of this is it's not about, I mean, there are issues of diagnosing in deprived populations, but this data doesn't relate to lack of diagnosis. No. It relates to compliance with NICE guidance. So it's what's sitting behind that. So is it the lack of patient compliance once their treatment has been initiated, or is it lack of compliance actually from a primary care GP perspective with actually NICE guidance guidance for prescribing?
Yeah, I think it's a mix of those, and I would need to dig into it a bit further, because I think it will be different place to place and practice to practice because of the way that we deploy, because UK general practice are private providers into the NHS, aren't they? And therefore their systems are all different.
Yeah, no, I get that. It's just, I'm sorry, I'm thinking about,
Yeah.
so if we're going to be targeting efforts,
Yeah.
it's about actually understanding what's sitting behind the data, so we actually target what's happening in to make the difference that we need to achieve.
Jason.
So I think it's really interesting. I mean, Andrew's right. There was a point in Hull where you couldn't go anywhere without having a blood pressure cuff kind of like shoved on your arm, because it was absolutely everywhere. But it was really effective because it was done in such a kind of a way that was quite low level. And if people went, "Oh, is that really high?" people could say, "Yeah, this is what you kind of need to do." So there is something for me about the opportunity with this to think a bit more creatively about how we really start to kind of promote that awareness in communities. And it kind of builds on, I think, the work the voluntary sector has done around the NHS app. It builds on the stuff that we've done around vaccinations, around who are the trusted people that can initiate the conversation. Actually, how do we start to think about an infrastructure which is not that traditional queue up at GPs, but is about saying, how do we have the conversation? The other bit I'm really conscious of with this is being very mindful of the health and equalities money that's gone into place, is about the investment here is probably around not only about prevention, but around how we keep people well. And actually, they're all the things that when the public health money kind of went. So some of this is about that creativity. We've spoken before, Chair, around the power of sport and community sport, and around do we do enough about healthy eating linked to children and people's agenda? Are we really maximising understanding what you do with food? So I think if we kind of viewed this as a quite creative, innovative programme, we start to do a number of different things. And I think the health and equalities thing is around, you can either scare the horses with a high blood pressure check and then have people queuing up, or you can have a really sensible kind of conversation. I think we've got an infrastructure through community groups, particularly some of those really diverse groups where we know there are particular communities where there will be high prevalence of CBD, and thinking particularly around some of our BME communities. We could probably do this quite easily. All it takes is that cultural change to say, let's take a non-traditional approach, let's do something slightly riskier, because actually that's the thing that's going to make the impact. And actually, people do quite like the idea of being able to pop into Tesco's, popping out, and then, because not everyone will have a watch, and I'm not sure people understand what the watch tells them, apart from the number of steps. So I think there's an opportunity. My plea would be, because this is very much place-driven, is that we have a consistent approach to this involving the voluntary sector at place, because I think probably we are the golden bullet that would have helped this to probably do what we need it to do.
And Amanda.
Yeah, thanks. And I think what we're all describing there is the making every contact count programme, and I think that's really important. Particularly, it's more complex when it comes to a blood test, obviously, but just thinking about the wider primary care contractor groups, there are significant alternatives where you can get, exploit every contact that you have with a practitioner, whether that be a dentist or an optometrist or a community pharmacy. There are a lot of services now available in terms of screening in community pharmacy, and I think there will be more coming on stream over the next few months and years, and just thinking about that and how we do that differently in terms of blood pressure. But I think and I can't remember when it was, Stephen, but we had a presentation in exec group about the work that the York Place are doing around booths where you can actually go in and get those numbers. The point then is, what do individuals do with a reading that is high, and then how do we signpost and navigate properly to get the right treatment? But I think in terms of improving population health and thinking about long-term outcomes, that systematic approach to understanding how you are yourself and making every contact count is really important.
Thanks. Louise.
Yes, thank you for a second question, Chair. The Population Health and Prevention Exec Committee is overseeing quite a bit of this work. And just by way of assurance, we have invested as a board, just to remind us all as a board, around our CVD capacity to tactically deliver on this programme. And certainly as a Pop Health Committee, we looked at a plan on a page which showed all of the parts of an effective system for CVD. So I think in terms of assurance as a board, perhaps if, Chair, you want me as co-chair of that other board to take this conversation back, seek assurance, make sure that that programme is being driven forward, and obviously working closely with Amanda on the point she's just made around making every contact count. We do have a mechanism for this, obviously working very closely with Angela's clinical lead.
That'd be really useful. Final comment from Michelle.
Yeah,
sorry.
It's a really important conversation about preventative and the maintenance of that prevention. And I agree with everything that's been said. I think we do a lot of actual screening. I think we do see it both in pharmacies and other areas. It's picking up about what Andrew said. It's how do we maintain those life changes. And I think that's why the recess is so important, the groups that you mentioned, Jason.
Yeah.
It's about actually, not just BME groups, but all the groups that we've got. How do we really, galvanise them in relationship to the maintenance, not just of the medication regime, but about healthy lifestyles, especially when you've got the cost of living pressures. People know what changes to make. It's just how do they do that when you've got other competing demands as well. And I think that for me is the important bit. I think we've got quite a lot from the screening point of view, be it AF, be it through watches or whatever, or blood pressure, etc. But how do we maintain that preventative stance in relationship to not just the medication regime, but the lifestyle changes that people need to make? And we've been talking about that for a long time, and I think that's really important. And working with GPs, they've done chronic disease management clinics for years, haven't you? But they still see that revolving piece in relationship to lifestyle changes. And I think that for me is the important bit in relationship to what Nigel's paper is alluding to. But I think it's a really important conversation.
Thank you. Peter, then Nigel.
Yeah, very, very briefly, thank you, Chair. This question for Louise, and it was the work you referenced. All of us have sort of defaulted to talking about services and programmes, and we kind of flirted with the self-responsibility end of this spectrum, and thinking about the work around engagement and communications, and how we maybe need to push that end harder away from making it about programme, to then liberate the resources for the most vulnerable and the most disadvantaged. And that's, I think there's something around taking the whole, as we shine a light on this, how we then look at that whole continuum and challenge ourselves to be really in the transformative end of it.
Stephen?
Well, Chuck, there, it's entirely in that territory. It's helpful that we do have a mechanism and a focus, and it is a priority within, as you've said. But this is about segmentation to me. And look at the resource position of the NHS and care. So I understand there's a global approach in primary care, but actually we need to segment our population on a populational basis to invest our resources to best effect. And so that, I think, is the job, really, about understanding what that means. And that's part of the segmentation, because it sort of assumes that there may be parts of our population with very little support will get there anyway. And so I just wanted to really emphasise that it's really important, especially when we're in this stretched resource environment, and it would apply to a number of other areas. So you wouldn't necessarily just do that targeting, would you, in isolation around CVD? There are a number of 3 or 4 other areas we'd be doing the same thing. And it's really important territory for this board to be in.
As we're just running to lunch, Anya, one more only.
Sorry, I know you wanted to close it down. I just wanted to briefly come back on the point that Michelle raised, and not to contradict your point, but I think there is a key point around some of our communities. The education levels around health are just so low. So it was the point that you made, and I know you didn't mean it like this, but to say people know what they need to do. Many people don't know what they need to do. In some of the conversations that we have, the very basics of just take more exercise, they don't understand that. When people are not going to school, when they live in maybe in an environment when they don't have that support, they haven't had that education. Some of what we think is really simple, basic stuff, parts of our community don't know that. So it's a huge, and as you said, that it's the sustained journey as well we need to go on. So I just wanted to make that point.
And it's at the very, very heart of our purposes, isn't it?
Absolutely.
Thank you for that.
I'm going to get me coat and I'm off on.
So, blown my ears out. Just almost 1:30, which is exactly when we thought we would break for half an hour. So let's take half an hour break. We're returning to our public board meeting at exactly 2 o'clock, and we'll be rejoining our agenda with the workforce update. So thank you all very much indeed this morning, and half an hour break.
No, don't blame me.
Shape shift into something that looks like a board.
Well, there's no way.
We're not on camera.
Can you find something else?
We are actually. We are. If you want to be seen on camera having a lunch.
We're still in public, aren't we?
Yeah.
Go what?
No filming just yet, thank you. Let's wait till we're all assembled. So, welcome back all to the second part of our public board meeting. Just to remind you again that we're being filmed, that the public can be watching us as we hold our meeting. So we left the agenda at the halfway point at the end of agenda item number 12. So we're starting this agenda at item number 13. And that's our workforce update. And I'm going to go to Jane Adamson, our Director of People, to cover this point. Thanks, Jane.
Yeah, thank you, Chair. So every time we have a board meeting, I'm doing a little bit more of a deep dive in the programmes that we've got. So for this month, you've got an update on what we're doing around retention as part of our HMY Breakthrough programme, and also what we're doing around the collaborative bank. You have a fairly comprehensive set of slides in front of you, and I'm not intending to go through each of the slides in the time that we've got allotted, but they're there for you to go through at your leisure, and there are other links in there so you can link through to the other pieces of programme that we've got. I think with the previous conversations that we've had today, and Amanda, you'll be talking later, I'm sure, about our operational challenges, then retention and collaborative bank actually are two areas that will be of real interest to the board, I'm sure. So you'll see on the first slide that we've got that you do have an update of what our whole programme covers, which is reflected in this slide here, so I'm not intending to go through that. I am, though, going to just give you a bit of a shaping of what we've been doing around retaining our staff. So to remind you that each of our organisations, our big organisations anyway, will be doing retention themselves within their organisations, and they'll also have retention plans. This is what are we doing at system level then that will have an impact on retention and will help us see what we're doing. The model that we use always has an SRO and it has a convener supporting it so that we can deliver against the actions that we do. And for retention, we've got Claire Hanson, who is the Chief Operating Officer at York and Scarborough, who is the SRO for that work. You will also, it's worth me just outlining for you that we're working on leavers as well as turnover, and there is a difference between those two things. So leavers are people that definitely leave the health and social care workforce, which is one set of metrics, and the turnover are people that leave their jobs but may well stay inside health and social care. And we are focused, and we have a system target around retention, which is based on turnover. So our target for this year up to the end of March 24 is 12.2%, and we're currently running at around about 15%. So we're not hitting that target currently, about 2.8% away from where we need to be around it. You will in the slide pack see, and it's on the screen if you want to look at it at the moment, where we are against that versus with each organisation, and you can see that there's some that are higher than others and some that are lower than others. But worth just you having that in your mindset when you're thinking about retention. And you may remember from last year that we ran a conference around retention and had all of our partners, and including primary care and voluntary sector and local government, talking to us around what retention meant for them. And there were 4 key drivers that came out of that. Flexible working was one of those, and I'm going to talk a little bit about flexible working. Early years attrition, I'm going to talk a little bit about that around preceptorship. Reward and recognition, compassionate leadership, they were the 4 levers. There's a 5th that's coming in on the back of the EDI work that we've been doing with the Assembly, which is what EDI elements actually stop people, keep people within health and care, and actually increase the amount of turnover that we've got that we wouldn't ordinarily want to have. So there's a separate piece of work that is also working through that. The work-life balance, the flexible working, was the second most commonly reported reason for leaving across all staff groups. So people not being able to be in more control of their work-life balance. That has increased for us on the back of the pandemic, really, where people got a little bit more say in some ways around what their work-life balance was like. Not in all of our staff groups, but in some of our staff groups. And we'd set up on the back of the conference that we had last year, and the surveys that we did, a task and finish group, which is the group that Claire is leading on. I'll come back to the flexible working and what we're trying to do about that in a second. We also have got some early career retention initiatives, because we know that people in their first 2 years of employment in health and social care has got quite high turnover. And we wanted to understand the reasons for that and what the difference around that might be. So we've got a multidisciplinary preceptorship task and finish group that's looking at organisations' preceptorship frameworks and what we might do at system level that links into the national preceptorship frameworks. So these two areas are really important areas of focus for us. We also looked at the exit questionnaire, so that's really poor in every organisation. I'll just come to it on here so you can see it. Not that you can see it very well, so I apologise for that, but you'll be able to see it on your screens. So exit questionnaires have got really low compliance rates in most of our organisations, so our ability to understand why people are actually leaving is really quite limited. So we have agreed now through the Workforce Board at our last meeting to a digital solution to that every organisation is happy for us to procure, to look at the reasons right across our system, so we can then find out what are the biggest reasons for people to leave and what a system intervention around that might really be. This is quite really interesting because it's taken some time to get to that point where people would be willing to say we'll run with one system that actually allows us to digitise exit, because at the moment that tends to be quite paper-based in our organisations, and certainly in the ones that I've worked in, the amount of exit questionnaires that you got back was between 30 and 50%. It's not high, is it? So being able to really understand that, and therefore your interventions being valuable rather than what you think they might be, is quite important. So we've got a proposal currently out with partners, and at the Workforce Board there was a lot of sign up to that, Jason, wasn't there? And that was a really good thing to see. And then the last couple of bits I just probably wanted to say was that we had our retention conference in November 23, and we just pulled together the outputs from that. We had Professor Michael West come to that, which was really well received, around compassionate leadership. And you can see out of the 4 levers that compassionate leadership is one of our areas of focus, and we'll be putting more meat on the bones, I guess, around that over the coming weeks. And we've already got some work going on around reward and recognition. So that's all I was probably going to say about retention, just so you know where we've got to, what the work is, the challenge that we've still got ahead of us around the numbers that we've got around it. I don't know, Chair, if you want me to take any questions on each topic.
I think that'd be interesting at this stage.
Yeah.
Jane?
Can I just ask some, on the slide that's got the rates, which has got the lever rates, what is the ICS? It isn't the ICB then? We're not listed here, it's just the providers. And is that, when it says ICS, is that the average of the providers? Is that what that means?
Humber and North Yorkshire ICS is the average of providers. This is NHS data.
Yeah, okay.
I think what Jane's asking, are you asking...
So the ICB isn't listed here?
No, the ICB 700 people are not on here.
No, they're not. Because this is NHS
because I had the same question.
Yeah.
Yeah. It's NHSE data, and they only report on trusts currently.
Right.
We've got other data that sits behind this.
Performance. Actually, the ICB employees, I think.
Yeah, it does. Yeah, we do have that data. I've just done is
cut
and pasted what came through from NHS.
Further questions? I mean, this is up my street, really. But I suppose, I guess, in really good organisations, not only do you fill in an exit form, you have an exit interview.
That's right.
So you meet with your boss and you talk to your boss about your working experience, and you talk about what was good and what wasn't and why you're moving on. And sometimes that's a really positive thing to do, because people are going on to great jobs, much, much better jobs, earning loads more money and make them happier, and that's a great thing. It's not all misery. So, if we were to be really good at that, we would be doing face-to-face exit interviews with our staff as they left, and I think that's the direction we should be heading in. You slightly glossed over the flexible working bit, really. Yeah. I'm assuming that for some people flexible working is a possibility, but for many, many more it's not. So, if unless you describe a 3-shift pattern working in an acute hospital as flexible working, because you could pick your shift to suit your needs. So I'm interested to know more about that and the work that you're doing around that, unsurprisingly.
Was yours about flexible working?
Well, just in relation to that, obviously, the flexibility afforded to people on the front line in wards or EDs is going to be less than somebody who, might be office-based for the majority of their time. But there are still things that you can do within that to deliver some degree of flexibility and actually autonomy, really, around, self-rostering, for example, is one of those. So and people working in those roles know that there's limited flexibility, but really welcome the degree of flexibility that can be.
Sorry, go on.
Stuart.
As a thought from earlier, we were talking about small community hospitals and such like, and somebody mentioned that if the staff went there, they might never come back because it was such a lovely place to work, or words to that effect. So I wonder, taking that as to whether we've got some method for understanding whether we have better or worse retention rates in high-pressured, big hospitals versus low-pressured, small CDCs, or some version of that, which might then factor into our enthusiasm or otherwise for those places. And in a similar vein, whether or not there's an ability to take people who have been under extreme pressure and give them a period of still working, but in a low-pressure environment for a while as a kind of respite to re-energise for the next winter season or whatever it might be. So observations rather than anything.
Yeah, I mean, you assume that working in a DGH, for example, rather than a trauma centre is less pressurised. I'd argue probably it isn't.
I guess what I'm asking is if we could understand the underlying causes in some of these alternative terms. Am I working in a small team, a big team? Am I in a big prestigious hospital or in a very small blah blah blah? Yeah. Then we could possibly work out other drivers of retention.
Yeah.
That's all.
I mean, we have a lot of data that underpins what you've got here. You'll remember from last time I was here, the challenge we've got outside of where data is ordinarily collected is still a big issue. So getting primary care data, for example, is challenging for us. Voluntary care sector data is challenging still. We've got to crack that nut still to be able to get into some of that.
And then the other, I'm only going to repeat, without deciding exactly where a low-pressure environment might be, if you've been under extreme pressure for a long time, still at work but being given a job which isn't under high pressure for a while, it feels to me like a good idea. Certainly in professional services, if somebody's worked their socks off for 6 months, you give them a gentle assignment for another month or two to get them back up to snuff again.
Jason, Richard, Stephen.
So I think that's really interesting. So I think some of the stuff that Brent was talking about this morning, which was around the stay conversations, the understanding how people are feeling, what are their opportunities, is at the heart of all this. And actually this isn't in isolation. So this fits into that whole piece of work we're doing around staff well-being. This is the whole stuff around... We are about to land a piece of work which is about the portability, which is I think what you're talking about, the ability to move into different kind of settings, dependent on if you're wanting to kind of develop. And at the moment, we have a system which is very much about retaining in organisations. So you retain staff in an organisation. And culturally where we need to get to is, my target would be about retaining people in our system. So you don't necessarily stay where you are today. You might move to social care, you might move to a community interest company. So actually creating that set of permissions, which is in our gift, to say how easy can we transfer from A to B. So at the moment, we've got people moving from, say, Andrew's organisation to a local authority, and it's taking 4 months to do the same job, because actually the system is so geared to, we need to do all these things. So how do we make portability an option? How do we use that as a, how do we reclaim secondment from being you've done something wrong to actually a positive kind of career move? But also, how do we better understand at an early stage how it feels to work? This is very much people-focused. And what we heard from the conference were people saying, actually, when people are interested in us and say, how are you doing, how does it feel, there's an opportunity to say, what could we do about it? And actually, the flexible working thing was as simple as saying, there may be some days when I may need to come to work a little bit later because I've got to take the children to school. And actually that permission, that compassionate leadership that says, that's okay because you're going to make the time up on Thursday, actually makes the biggest difference. So what was really interesting in the room at that conference was so much good practice is happening around retention that people are not sharing, but actually it's really simple little things. And actually, retaining people in our system, actually if our future workforce is about skills, not roles, and the ability to move skills around our system, then actually retention becomes, really, really attractive to people, because people do want to stay. They are quite disappointed that the last conversation they have with people is about leaving rather than, what can we stay? I'm also really conscious that this is largely NHS data, and actually part of this is around, we need the same retention conversation with local authorities, the same kind of retention kind of conversation across the whole system, because the future workforce would be about moving between different parts of our system, not just about the NHS. So we've got the data we have already. There's a whole wealth of data we're collecting around other parts of the system, but actually the positivity and the enthusiasm, the survey we did around the retention had a massive staff response.
Oh, it did. Yeah,
it was, I was so surprised by the numbers of people saying, we've got some really simple ideas about how we retain, and this has been a really positive. It's the first ever conference we've had that isn't about recruitment, but is about retention, and that was really, really positive.
It was really positive.
Thanks, Jason. Richard?
Yeah, I was interested in the correlation between people who leave within the first 12 months and flexible working. Certainly at my trust, we've had quite a number of people who've left within the first year who've said they never really felt a sense of belonging, because where they used to previously work for the NHS and they were part of a team and they got to know people, they come back and it was a very different model of working. And I just wondered if that's coming through in any of your research.
It's coming through in the work-life balance that people are asking for, and some of the details sat behind that is how people feel when they're in a physical work environment versus when they're in a virtual working environment, and if they've moved around, the teams that they're in. So you're right with the team bit. It comes out loud and clear. It's come out in our values work as well as part of our ICB work. But yeah, thank you.
Stephen?
Just 3 points, different ones. I'm just going back to the graphs. The thing that I'm trying to get my head around is what's our target rate?
12.2%.
We want to get to 12.2%.
Currently, we're reviewing it
on that bottom metric, Jane, on the turnover or the.
Well,
I'm looking at. Well, I suppose I'm talking about. Presumably, we want to retain more people.
Yeah.
So, what's whichever metric we're using?
Yeah.
What are we aiming for? And what do we expect to deliver in the next 12 months? I think it's sort of what I'm interested in. Don't answer the question now, but I think in a way it's helpful to see the bigger picture. Unless you've got the answer to that question, that's fine. Now that's good. So that's the first question.
So 12.2% is the current one that I said at the beginning, up till the end of March 24. That's what we were aiming for in this year.
And where are we
against it? We're at 15%.
Right, so
against it. Yeah. So we're about 2.8% away from it. It's never hit it on any one month either. So when you look at it on each month as well as overall.
Sorry, yes, the other direction. I'm sorry. Yeah. So we're at 15% against 12.5. And what's our target? Have we yet to set it for 24?
We're setting that this Friday.
Right. Okay. Yeah, that was my
24.
That was my first point.
National average is 15%, I read on the internet when I was looking at this, thinking, well, I wonder what's normal. Normal is 15%, so we're going for
on
less
average,
than normal.
I think you're talking about there, aren't you? And then on the point that Stuart raised, I think this is quite important. So, and picking up on what Jason's talking about. So there's a bigger picture, which is how do you create an environment where you've got much smoother transition between different sectors. But even in the NHS sector, it's a bit round what Jonathan was saying earlier when he was talking about what was going on in Hull and Grimsby. We've got to get used to the idea that the workforce ought to be interchangeable between different parts of the same function. So I mean, I've got direct experience of that elsewhere in my earlier career, where the only way to keep emergency services, whether it was the sharp end or the less onerous end going, was by the same staff rotating through. And I think that's a huge agenda. in terms of an integrated workforce model. So I just want to flag that, because I'm not, it comes back to that point about within our overall workforce plan, what are those areas that we're going to target in that way? And that mitigates to some extent against bank and agency and recruitment issues if you go down that particular road. My third point was just to flag something, because I think it's something you might want to come back to. Everybody wants to work flexibly. I do. Everybody does. Not a problem. However, there are issues, going back to what Richard's saying, there are significant issues behind this in society and in all walks of life. And in public services, I don't think we've seen it yet, but there is a directive, I think, coming through NHSE, which is about minimum standards around flexible working wherever you work in the system. So that's about people. So real challenges if you've got large proportions of your workforce working from home, without going into the details. So this is about how do you get, so the work-life balance and benefit to individuals is one thing. Work-life balance is really important into the effectiveness of organisations. So I think we haven't cracked that yet. I'm just making that point for further conversation. And there's some work to do on it. So it's just to throw that particular point in for future reference, and it is a highly relevant actually to the conversations we're having about ICB evolution right now.
Yeah. Thank you, Stephen. Just Jane, going back to the bank and agency workforce and flexibility between organisations. And I think we should really be aiming for flexibility with local authorities as well. Because there's an issue, I think, around leaving your pension, your local authority pension and an NHS pension, and all of that. And I assume that there's some national work going on with that. But I think we should be looking for easy ways for people to passport around the public sector in an integrated care system, and not making that hard for people, and not making it, it's a one-way journey and you can never travel back. I think we just need to be really, really good at that. Now, maybe that does need national help. But
it's the portability that Jason's been referring to, but you're
proper
right,
aspiration.
it also does need, the pension challenges, for example, around that are difficult.
Yeah. So thank you, Jane. Look forward to updates on all of that.
Do you want me to mention collaborative bank?
Yes, please.
Yeah. Okay. I'll be quick, as quick as I can, and then I can take questions. So a bit like the previous one, we've got our governance arrangements for this. So you can see by the slide the numbers are different task and finish groups they are, and Lynn Parkinson, who's the Chief Operating Officer at Humber Teaching Hospitals, is the SRO for that. So just wanted you to see that. This slide explains why I have a collaborative bank. It's dead straightforward. We're going to spend about 69 million, probably more than that, Jane, on agency spend across our system. For the organisations that have already got collaborative banks, we know that that'll give us about a 2.3% reduction. And for that, that's about 1.6 million cost efficiency for us. So that's one argument for having a collaborative bank. The other one is helping you to manage your agency costs, because at the moment an organisation will try and fill it through bank, fill their gaps through bank, and then if they can't fill them through bank, they go to agency. And we've positioned a number of models for people to look through. It's in your slide pack, but I'll just go to the slide. So we said, do you want a lead employer model? Because that would be one way of setting up a collaborative bank. Do you want a distributed employer model with a host payment model, or a distributed employer model with a distributed payment model? And I won't go through each of those. The detail is there for you. But you'll see that what the preference was from our partners in the system was to actually still carry on with their own banks internally, then to have the system collaborative bank. So if you couldn't fill your shifts and your rotas, you would come to us for that to be filled. And then if that couldn't be filled, then it would go to agency. That allows us to have more control and allows people to have careers that span across our whole system, and links to what you were saying, Stephen, about people moving around more. So that's the model that we're now progressing with through the work that we've done. Go on.
Oh, it was only just to be, I'm not going to second guess the conversation. It just sounds like there's a lot of layers in that. There may not be.
There isn't really, no.
No, I just want to be assured we're not creating some sort of, our agenda about making sure we don't create more bureaucracy. If there's lots of different banks, if we're on that, that's fine and it's not a risk. But I just wanted to.
Yeah, we are on it. I mean, there was 3, 4, 5 different and more different ways of doing it. What we want to do is get a collaborative bank up and running in a reasonably timely period, so that you can actually, and I'm sure we'll flex things as we're working it, because we'll learn, won't we, as we go along. We've not had a collaborative bank before. We're collecting all the bank staff survey data for the end of January, so that's our time frames. And then we've got a business case that will be finalised and in consultation by the end of Q4. So, in the next couple of months, really. This is a 12-month piece of work.
Understood.
To get it.
So what was in my mind is, if you had an integrated collaborative bank for Humber and North Yorkshire, that feels like quite a good thing.
Yeah.
And I think that would be led by providers, not by some sort of provider. I don't want to debate it now, but it was just whether that's what we're thinking, or whether we've yet to look at those sorts of options.
We've looked at those options. So where we've got to is what they've all said that they want from it. So they'll run their own. We will have a software solution for a collaborative bank, which almost is like a virtual. So people stay employed by their organisations. We'd position them where those shifts are available.
So my subsequent point, it'll be quick, is coming back to returns. So our target was 1.6 million this year. Are we going to hit it?
Well, we haven't got one up and running yet.
All right, okay. It says 23, 24 on my slide. But anyway, that put that to one side. So my second point was 1.6 is not enough in the context of the challenge that we've got. So one assumes we can review that figure.
Can I just respond to that?
Yeah, of course you can.
It does say 23, 24. That's why I said.
End of Q4, 23, 24. So we're in quarter. That's
so we're on target for 1.6 million.
You'll get, your procurement exercise commences Q1, 24, 25. If you look at the slide, and then the software solution. So having it in place in Q3, 24, 25.
I'm looking at a different slide.
And
looking at opportunities for financial savings.
And this is the collaborative bank piece, so that doesn't mean to say that there isn't a lot of work going on around agency spend inside the organisations, because you're right, 1.6 million isn't enough. 2.5% is what average that people are getting if they put a collaborative bank in, until we've fully shaped it and finished the business.
So that's work in progress.
Yes.
Do you want to make a quick comment, Jane?
Yeah, just in general terms. So in terms of bank usage, so we have trusts with lots of vacancies, and at the moment staff can go on a bank and do extra shifts. But they will not fill all those extra shifts from their own staff. So the degree to which a collaborative bank is going to, this is my personal view,
in an individual organisation.
Yeah, because they've already got, every trust has spare shifts that are not filled through bank. So the fact that someone in York and Scarborough still got shifts unfilled, and in Harrogate shifts unfilled bank, what benefit is the collaborative bank? Now it's going to be interesting, it will be interesting to see, because I still have a theory that, so your point about there's going to be lots of transactions that work, so there's not going to be many, because if you want to do a bank staff, you'll do it in your own trust, you'll do it in your own ward, and the fact that you want to go to York to do it is probably here and there to, do you know what I mean? I just don't think you're going to get a big take up, but the real financial benefit is on agency. And the premium is on agency, and the majority. So it was interesting because in terms of our system, NLAG, for example, have a lot of agency nursing, and if they could be switched to bank, that's a massive. So there's other big opportunities for financial gain, which I personally don't think is to a collaborative bank. It's about switching agency to bank, and also the medical agency in particular is about the trust that can't recruit, like. NLAG has the highest agency spend. They're in the top 3 as a percentage of turnover in the whole country. It's absolutely massive because they cannot recruit. But those medical staff that may exist in York, Scarborough, Harrogate, if you pay them enough, might go to NLAG, and particularly Hull. And that's the benefit of this group model, is using medical staff differently. So the greater prize is, in my personal view, it's switching from agency to bank, and stopping agency in the first place across those group of providers, particularly basically, and medicals. Those are the two bigger prizes. Because I personally think Collaborative Bank is actually quite small in terms of any gain, because if you want to do a bank shift, you can do a bank shift
You
now.
put it better
You don't
than
even need a Collaborative Bank.
You put it better than me, because I was including agency in my thought process.
It's agency, that's the bigger prize.
You're stopping that. At the moment, they'll go straight from, you can't fill a shift through your bank, to agency. And the Collaborative Bank puts an extra step. And it's not more bureaucracy. You'd have complete transparency about what's happening across your system, which then allows you to reduce that agency spend. That's where the savings come from. Yeah.
I wonder if you need to have more of a conversation about this outside of the meeting. So,
it's still work in
I can
progress,
hear
isn't it?
quick comments
Yes.
from both Andrew and Jason.
Can I make a plea? One of the biggest things at the moment in agency, which we're finding, is if we want to employ a GP, they're all through agency. Agencies are going in and signing up all the new recruit GPs, and do you know how much it costs me for one GP alone? 15 grand in agency fees, and I can't. 15 grand. I've got two that are interested, and it's 30 grand. I've got to pay 30 grand for them before they even start.
For you as agency staff?
No. They apply.
Oh, it's like a recruitment.
So recruitment thing. All of them are joining a recruitment agency to get them work where they want it and to negotiate on their behalf for ease. £15,000 per one.
Right.
And I can't get hold of anybody that doesn't come through these agencies now. They've all signed up to it. So it's a real big issue.
Jason.
Well, I mean, sorry, Pete, you're looking sceptical, but I'm
No, I'm not. I'm not looking sceptical. I'm looking appalled. And it reminds me of the same conversation with children's social work. And it took a massive amount of pressure onto the Department for Education to start to get some national change. So I'm not looking sceptical. What I'm thinking of is, where's our voice to the department and through those political levers we've talked about, start to really, get into this, because if this is happening in Humber, North Yorkshire, I cannot believe this is unique. So it's a national issue. Where's the lever? So not scepticism.
No, they're just great because they do all the work for them, so they don't have to do it. They just find them a job. So it takes all the pressure off the individual, and they find their job wherever they want, but they charge you 15 grand. It's ridiculous. I've said we need to get into HIMSS quick. So they're like, don't sign up. We'll give you 15 grand. We'll give you 10. Come and work for us. Yeah, right. Why am I paying them?
Okay, well, this is definitely for another session. Jason, your final comment, please.
Just really quickly, so there is something about, so I go back to not seeing things in isolation. If everything else in our workforce transformation programme around recruitment and retention kicks in, then we become less reliant on agency and bank. So there is something about, it's part of a much bigger story, and actually if we get the other bits right, that's really important. There is something about, we're talking about agency and bank costs in terms of the NHS, because that's what we measure, but I think there is equally the same conversation around social care, children's social care, around those kind of pressures, around how do we collectively kind of work together. And the bit I don't want to lose sight of is I think we are starting something. What this looks like in a year's time may be different, but I can't underestimate the amount of work that's had to happen, kind of led by Lynn, in talking to a group of providers around a table to get them to the point where they go, actually we want to collaborate, actually we see the value in working together to address a common issue, whereas up until now all this has been organisational kind of focus. There is something about not losing sight of, it's maybe not where we'd want to start with ambition and aspiration, but how we've done this and the fact we can now have the conversation next around what next for a bank is actually really positive, and I think that's that system working together, that system kind of taking control. We've listened to what they've said about what they want, they've designed the model. I think in a year's time we'll be looking at something different, but we need to allow it to play out first, and I think that the team around this have done the most fantastic piece of work, having a tricky conversation about money and about people and getting to a point where they say we can all collectively, so I thought this was going to be difficult, they all went, yeah, we're really happy with this. So I think that needs to be recognised.
Yeah. Thank you.
Yeah.
Okay. Thanks, Jane. Let's move on. More quickly, perhaps now, Jane Hazelgrave, our Director of Finance, our finance update. Your third shot at this today, Jane.
Hello everybody. So we'll see. I'm not going to go through the report in detail because we do that at every board meeting. I want to contextualise the finance report this month. So this is the financial position as at the end of November. And if you remember, we had some additional resources as part of the NHS reset. So the additional resources that were played out into the NHS nationally was £800 million, and our share is just over £17 million of that. In addition, there was some new guidance in terms of elective recovery funding. So that has been, we were asked as an ICB not to reflect that in our financial position in this report, but some providers have chosen to do it, so we've got a little bit of a hybrid position. So you'll notice that at month 8 that the year-to-date variance, if you like, was £21.5 million overspent. 5.2 is actually in the ICB and £16.3 million in provider sector. The ICB position will go to 0 next month, so there will be some further improvement. But you will notice there is improvement as well in this month also, because providers have reflected these additional resources in their position. So at month 8, the system had a deficit of £52.9 million against a planned deficit of 31.3. That's 21.5 overspent, but it's still an improvement of £12.4 million. So that's really quite a good position, really. I wasn't going to go into any more detail in the review because, again, it's this hybrid, whereas at month 9 we will have a much more detailed for year-to-date position incorporating all the flexibility. And then if we move on to capital, we've actually got a position where we've underspent by £28.4 million. And as you would expect, that when we do month 9, we'll be doing a much more deep dive into capital to understand where we are going to be and if any of those underspends are going to be played out to the end of the financial year. So at the moment, we're doing that work with each of the individual providers, and we'll come up with that at month 9. So I wasn't, to be perfectly going to say much else really, because I think the main report is a little bit in line with the others, and it's a bit of a hybrid in terms of some reflecting the reset and then other bits not, but that will be fully reflected at the next meeting.
Thank you, Jane. Stuart?
I wonder if at period 9, after making all those various, what shall I call them, catch-up adjustments that you were just describing, I wonder if we could have, even if the centre wants it, a sort of proper reforecast for the year end, because of the risks that are outlined in the report, which haven't gone down but are still big numbers. It's sort of beholden on the board, I think, to have a proper view rather than a sort of forced view of we haven't changed our forecast. And for next time, Jane.
And Stuart, in here we do have, the risk section, which has, again, significantly improved and will improve further. So the risk section at the moment, the net risk after mitigation is £26.9 million. Whereas last month it was 62 million, so that's gone down. So that risk section in particular.
Could I just make a quick point on this, just to help us with the conversation? Next time's February. So actually, in my mind, if we're going to declare a variance from that's when we do it, because there's no other opportunity to do it, is there?
Well, earlier on, Jane mentioned that the centre wasn't insisting on a period 9 reforecast. I'm
that's
saying
the centre.
For our board,
we're
singing the same song.
I'm not disagreeing. I'm saying we can't really, because of commit to that this month. I think by the time we get to next month, we'll be quite clear about whether that. I mean, I think we're still. Jane, forgive me if I'm being over optimistic here. I think we're still thinking that it's just as likely we might be in the right direction. So.
I might be. I'd like, rather than us just roll over the 30 million deficit, I'd like a sort of proper view, I guess.
Yeah. And we do have those risks on the section 7, which talks about the gross and mitigated risk. But we'll go through that and make sure, like you said, at month. The thing is, it's when this paper is written, isn't it? Because this is actually November, because we haven't actually got the December information yet as of the 10th of January, so we're just that little bit out. But when the next board meeting, it will be the month 9 position, and we'll also have a bit more clarity on the other bits of information.
I'm particularly looking forward to the forecast of prescribing costs for the year.
Yeah, for definite.
I mean, it would be really helpful to be looking at December's information, even if it was just at a high level now. So I can see you couldn't have the completed accounts, but it would be good to be able to have a high level overview of the month just gone by. I know when I was at York with Simon, we worked really hard with Andy Bertram to get a high level overview of what we thought the previous month would look like as early as we could. And it is possible to do, it's not impossible. The Trust can do it. So it is possible to have a high level overview, what came in, what went out kind of overview, really, really quickly. I mean,
Well, what York and Scarborough do what they call day one reporting, so that's what they do in their organisation.
Oh, well, that's what the chair likes.
Yeah. not all the trusts do day one reporting.
I was going to say, I don't think it's as straightforward as that. And the point I want to
we don't do day one reporting at month 9 because of the national requirement.
The point I want to make just
Where have you come from?
The point I want to make just
If by magic Mr. Ben walks back in the room
in the meeting today is it is highly unusual for not to be a requirement by now to report to the centre exactly what your outturn's going to be. Now, the reason that's not happening is there's still a national discussion going on with the Treasury about what the sort of outlook is and what the planning arrangements are for next year, which is all this is all relevant to. So I think Stuart, I'm with you, but I think we need to do it later than where we are now because we're not in a position to do that properly.
Just one other final comment about month 9 is that month 9 has been extended because of the strikes and they've asked providers to collect strike costs. So the month 9 position, that's Simon's talking about, has been delayed due to the cost of strikes. So that's what providers are having to work at the moment.
Yeah, that's quite a key factor.
Yeah, so that will be brought in. So that also muddies the waters, if you like, as well, because the reset was based on no further strikes. Oh. There have been further strikes. So you've got the reset implications and strike implications, and we need to take both of those into account.
Is that month 9.5?
Well,
in effect.
Well, if I might, so just to that point, there will always be, whenever you're trying to do a foot, there will always be things that aren't decided. So if at the next board we get whatever we have, with some caveats that say here are the things we don't understand properly, that's fine, but we ought to have a decent stab at whatever we think it's going to be.
And the broad principle is the closer we are to the information we receive, we have the same conversation with you, don't we, Amanda, around the performance report. Who wants to know what happened in August, in December? You know, who's interested in what happened in November when we're halfway through January? You know, the closer we are to the information we're looking at, the better the decision making and the better the way that we can run our organisation as a. Thanks, Jane. Now moving on to the performance update, Amanda.
Thank you very much, and it is very much the same challenge in that in the report there's a mix of data. I think the latest is November, but there is October and even earlier, and that is one of the challenges that we face. And also just to flag that the impact of industrial action is not only felt on the financial reporting and the position, but on the performance and the impact on our patients in terms of delays or cancellations, which again is being worked through both in December and in January in both periods of industrial action. Having said that, there's a lot of information included in the pack, including actions that are being taken in all of the different areas. And I think following a discussion last month that I had to leave by, we are doing some work just to look at this performance report to see how we can improve it. And so any feedback to me or to Sean is welcome. Just in terms of particular areas I want to pull out. In terms of urgent emergency care, the performance back in November was at 68% for the ICS, which was ahead of our plan at 63%. The unvalidated data for December looks that we hit about 63% for that 4-hour target, and that was below our reset plan. However, in the last few days, with a lot of the actions that I've described at the top of the meeting, it looks like we're closer to the 70%, and we're obviously still aiming as a system for that collective 76% for the 4 hours, which is important in terms of patient experience, and there's a lot of work going on across the system to achieve that. And we're also working with ambulance colleagues on the Category 2 30-minute performance, again, which is has been challenged in December but is looking to have improved. Just in terms of planned care, the number of patients waiting over 65 weeks continues to be ahead of plan, and we continue to improve. But again, just the caveat of the industrial action, what that will do to that in terms of the slowdown on that, we need to work through. And we have no patients waiting over 104 weeks and a projection of 27 over 78 weeks. And we are continuing to improve the long wait position, which is positive, although the waiting list is growing, and we'd expect to see that continue with the industrial action. Obviously, a lot of work happening through the collaboration of acute providers in terms of the elective position, so planned care, but also work ongoing in terms of diagnostics, improving access and flow through diagnostics, and the cancer standards. And cancer treatments very much contingent on flow through diagnostics and capacity, and again a lot of work through that. There's a challenge in terms of mental health and learning disabilities, but a lot of work happening in that space with the collaborative and some future ambitions. And
I think it was that very bland
That's October.
sentence that made me think, all indicators are off plan in mental health and learning disabilities and autism. I was thinking, why isn't that on our BAF? If we're not achieving any of our targets there, why aren't we having that on our BAF? Because that's a pretty bald and appalling statement, isn't it?
So we did a deep dive at the System Oversight and Assurance Group into mental health, and I think one of the big challenges that we've got is the data is October. So actually understanding the actions and the impact of, and Michelle will clearly be closer to this perhaps than I am, but the actions that are being taken are slow to percolate through in terms of what that actually shows.
So I would propose that let's do that first before we take that step. Because just on that,
Yeah.
But I think if it is validated, then I
Yeah.
think what you're saying is correct.
Yeah.
But let's
Yeah.
that.
Okay.
And let's not accept that it takes 3 months for information to come through to the board. Let's push that harder.
Yeah, my hands and the BI's team hands tied a little bit around that. Yeah. But it's a good point, and let us do some work to see what we can bring back in terms of assurance.
Clear, and then we can take the decision.
Yeah. And then the last thing I was going to say, just that's actually not on here, but just to flag, because it's an important part of our system in terms of primary care, we are ahead of the trajectory in terms of additionality for appointments. And we've continued to discuss the 14-day 85% target, which is not at 85% because it's not always clinically appropriate for long-term conditions patients to be seen within 2 days. So there's a data cleansing exercise, but also to say that we've improved our position in dental recovery, and I just think it's worth flagging that because of the challenges in the profession. And then we've talked a bit about workforce, haven't we, Jane, and just in terms of the turnover figure of 14.7% and the work that we're doing on that. So that's all. Again, any comments in detailed conversations around this and how we improve it, really happy to work with Sean and I, please.
Okay, thank you. Any further comments?
I'm sure you would expect me to respond as always. I think I've made this in relation to mental health. I think it's good that we're doing the
Might need to check you that you're in a microphone. Can't really hear you. Maybe pull that one forward.
Can you not hear me?
That's better.
now.
Much better.
Yeah, I mean, obviously I've mentioned this several times now, and I mentioned it earlier on today, but for purposes of this meeting, from a mental health point of view, we are doing a validation exercise anyway, so I think that's helpful, Stephen, to say. We do need to be clear around what the trajectories are, because obviously we agreed a different trajectory when we set off from a year point of view, because we would never meet the long-term plan because of the financial piece, and SDF has been removed since then as well. So we have got a chief executive in the ICB that's leading the data collection as well, so we'll need to dovetail the two together. But since the last meeting, I have sent 3 personal reports into the Integrated Care Board with the data position and into the regional office with the current data position if we migrated the information from the correct data source. Yes, we have still got some shortfalls, but they're not as significant as on this report. The other thing that we do need to do is to identify what organisations are sending data where. Because obviously there's some data going into the South Yorkshire system that we should have recognised here, and there's a lot of data going into Cumbria system that we should have here. So we're also doing that piece of work as well.
So I think there's just a technical point, not to. I think I agree. Is I think we should be saying if that is clear that there are issues about data, we should either not be bringing it or be saying that. I mean, I don't want to get into debate about it now, but because we heard a little bit about that earlier on in different contexts. So it's not just about this, but I think we should simply stick to the fact, as it stands, we need to get to a position that's clear quickly. So I'm with you on that, and then we can take a view as to what the position is on the back of that.
Yeah, we'll do some work on that, absolutely.
I do have some feedback, which I will talk with you more personally, but there's 2 things really. So on community health, 2 out of 2, community services waiting list, it says overall, size of community waiting list is below plan at 19,957 people. Well, The plan is nobody waits, isn't it? Not that we've done well because less than 19,900 people are waiting. The plan must be zero, mustn't it? We might have a target that we're setting ourselves as we incrementally move to that, but the plan must be zero, that nobody has to wait, and that it must be what we're working towards. And the second thing that this never tells me is whether what we actually provide is good quality or not. So, you know, did we provide all that many things, and were they great? Did people appreciate them? Did it work? Now, I don't want to ask for more than this report's supposed to deliver, but those are the two things that always, when I'm reading this report, make me go a bit red in the face as I'm reading it. Teresa.
So just on that note, there are actually a couple of quality-specific metrics on the broader BI performance report, but they don't cover all the ground we would want it to cover. So we are working with BI to actually develop a quality report that is fundamentally it's for the quality committee, and we will bring highlights of that to here. It will also cover actually some of our statutory requirements as well, because at the moment we don't report on those either.
Thank you.
Could I just in terms of that, I think I agree. I take the point reading it like this. It's not one single waiting list for one thing. It's a lot of providers and a lot of different services. So I think there's also more work we could do to make that clearer. And you're right. In an ideal world, nobody would wait for anything. In some cases, it's clinically appropriate to wait.
Yeah.
So we just need to get that information clearer. But it's helpful feedback. Thank you.
More human, really.
Yeah, easier to interpret, yeah, absolutely.
Okay, let's move on. Let's move on to item 16. This is to you, Karina. You're going to talk to us a little bit about the Partnership Governance Review, and you're going to share with us a petition sent to this board.
Yes, thank you, Chair. So I won't go through the paper in full. I'll assume that some of it, well, that it's all been read, but in terms of obviously the governance partnership review, we obviously conduct as an integrated care board a review of our governance arrangements on an annual basis. We did that last year. We propose to do that again this year. But to support new integrated care systems and new integrated care boards with their whole partnership governance, self-assessment and development, NHS England, along with a multitude of stakeholders, have produced some guidance for us. It's not mandatory, it is very much for us to determine. So in terms of the paper that we've presented, we've just given a summary of that guidance. We've specifically focused on the ICB element because we are about to start that piece of work in this quarter 4, in reviewing all of our governance, which will include the integrated care partnership as well as the integrated care board. But then, as the paper highlights, we've picked up where the other review, where we think we are already doing our own self-assessment and review of the other areas that NHS England are advising it would be beneficial to look at whether your governance is effective, that being place and provider collaboratives, which links to some of the work we're already doing as a system and resetting the system, and also around mutual accountability, quality performance and resources, and those two things are quite linked, inextricably linked. The third area is around the provider selection regime. That only became effective from the 1st of January, so therefore it's really not possible for us to do a self-assessment on that at the moment. It's a whole new process that has only just come into effect. So we've proposed that be conducted later this, in the new financial year and later in this calendar year. So I'm happy to take any questions, but the papers, that's broadly the summary of the paper.
Louise.
Just a very brief one, Karina. Just in terms of the Pop Health Board, because it's a subcommittee, will it be wrapped up in that, or is that separate? Yes. I'm just conscious we've done our audit recently, so thank you.
Yeah, we'll pick it up. Yeah.
Great, thank you. So that's a job near you in the course of the next 3 months for everyone. All of us will be involved in that. And I think I've got an opportunity to meet with each one of you individually between now and the end of February, early March as well. So that's part of the same process. Thank you, Karina. And the petition, please.
Yeah, so the second part of this item is, and the board will recall that we agreed a petitions policy towards the latter end of last year. We have received a valid petition. It's in relation to the Humber Acute Services consultation. It's for the board to receive and note. As the paper sets out, there is, and as Anya has already alluded to today, there is an extensive public consultation exercise taking place around this. So all of the detail of that will then be fed in, and petition, again, along with all other feedback, will be reviewed by the Opinion Research Service that are analysing the consultation feedback. So it's really just to note receipt.
And could I just clarify, is that a petition that's also gone to the Hull and NLAG boards? Or do we know? Or is it just to the IC?
The consultation is an ICB.
No,
so
I'm talking about the petition itself.
They're aware of it, yeah, the two.
But it's just come here?
But it's coming here,
right,
yeah.
Okay.
Yeah.
Mark, and then Jason.
Yeah, just one real quickie, Karina, and apologies if I've missed it somewhere, but do we know how many people signed it?
4,689.
Thank you. Where was that? I couldn't see that.
Through the link.
Oh, right.
It's in the link.
Jason.
So I just had a question about the process of kind of receiving the petition and what happens next, because clearly presumably there's some response to say we've received it, thank you, and potentially a kind of a conversation to understand the concerns. It's almost the bit around our process very much is about how it gets here, but what we do with it. And I think there is with petitions, there's always a bit of a risk in terms of it just landing in a room and going, thank you very much for it. So I wasn't quite clear from the policy what happens once we've said, thank you very much.
So from our perspective, because this is linked to the Humber Acute Services Review consultation exercise that's already underway, this will go into that particular process.
I get that. It's the politeness of a board to...
Can I think it's a really good point from previous experience. I'd like to suggest, if we haven't got, even if it's not within the policy, Chair, that we formally write to whoever submitted the petition. I was saying that we've considered it here, etc.
It sounds as if we have.
So is that what we're doing?
Just to clarify, when we received it before Christmas, we acknowledged it, advised what was going to happen. We provided the link
so now we'll do
to the live stream,
right, okay.
and then we'll follow that up as well.
Yeah.
And we explained it
live.
as the consultation.
Thank you, Jason. Karina, the baton stays with you. Agenda item 17, policies reserved to the ICB board. You're going to talk about the information governance framework and also an information governance incident report.
Yes, so the first one's the framework. The information governance framework's required to be updated as part of our data security and protection toolkit submission that we have to do annually, that provides assurance around our lines of accountability and responsibility in relation to information governance and the general data protection regulations. This is a policy that we have reserved the right for the board to approve, because everybody around this table needs to be aware of their accountabilities in relation to information governance and protecting personal data. We've tried not to make it too exhaustive in terms of that, in terms of the framework, but it has to cover everything that it needs to, and obviously will be adapted periodically as and where we need to, and regulatory requirements require us to evolve. But as it stands, this is our framework at the moment. Here for approval.
Thank you. Can we approve that, please? Thank you very much indeed. And moving on to an information governance incident report.
Yes, so again, we just, as we've reported this to the Information Commissioner's Office, we need to make the board aware. This is an incident that happened internally within the organisation, as the paper describes. We're not aware of any actual breaches as a result, but because of the internal nature and the nature of the breach, and the incident, we can absolutely give assurance that there isn't any data that has been breached, but it was very much internal, so it will be staff having access to information that they shouldn't have had access to, and that could be in relation to patient information that we hold. It could be personnel records, it could be other information. But having done all of that and reported it, as you will see, there's no further action required from the Information Commissioner's officers. They're happy with the processes that we've undertaken to investigate and look into it. We've also put in a series of additional actions to make sure that it doesn't happen again, as a result, working with our digital providers.
Any questions for Karina? Anything anyone wants to ask? Richard?
Just a bit of an observation, I guess. It looks like they've remedied the technical problem that caused it, but it does look like there's an awful lot of spring cleaning still to be done. There's a vast amounts of data which brings a risk, so I think it'd be nice to know that there is going to be a piece of work to work out how to deal with that. And also I think they mentioned similarly future retention policies in terms of ensuring that this data doesn't grow in these shared drives at the rate it has done in the past. So is there an active piece of work ongoing for both of those?
Yeah, there is, and there is a piece of work, because this is about our non-SharePoint cloud-based arrangements, so this is about server-based files and folders, and the intention is to move away from all of that, so there's a whole data cleansing exercise and all the review of retention and pieces going on as a result of that.
Thank you. Thank you, Karina. Let's move on to item 18. Item 18 is, at the request of the board, is good news. So we get a great pack of information in which we can read a lot of the great stuff that's gone on in this organisation, the great people in this organisation, our achievements. So I hope, as alongside your board papers, you always make sure you peep into that item and have a look at some of the good news. Item 19 is the Board Assurance Framework Review. This is where we get to the end of our board meeting and we ask ourselves, are those risks on our BAF the right risks for the organisation as we now understand it at the end of the board meeting? Broadly they are. I'm happy to wait for your view around the mental health risk, but I think that is probably really important. Is there any comment anyone wants to make about either those BAF risks or the way that they're rated, given the conversations that we've been having today? Everyone's content with the BAF as is?
I think so.
Yeah. Okay, lovely. There are no matters for any other business. You'll see that our next public meeting of this board will be on Wednesday, the 13th of March at 11:45. I thank you all very much indeed for your time and attention. And certainly to anyone who has been live streaming this meeting, thank you for your time and attention too, and good afternoon.